Okay. So hi, hello everyone. Thank you for being at the first French healthcare conference at the Expo Dubai 2020. This morning we will be talking about future perspectives in healthcare and urban planning. I am Joanna from French Healthcare Association, and I will be a moderator because Virginie who couldn't make it this morning. So I will try to talk on the subject with our intervenant today. So maybe I will let you introduce yourselves. We have online Michael Lozano.
Hello, nice meeting you all. So my name is Michael Lozano. I'm the president and co-founder of the company Tesalis, specialized in healthcare waste management. I'm happy to be with you today.
Thank you, Michael. We have also Mr. Ben Nasser from IA Life Designer.
Your micro is mute, Elodie.
What you said?
Elodie, your microphone is mute.
Okay, do you hear me now?
Yeah.
Okay, thank you. So I will let you introduce yourself.
Me?
Yes. Okay. So we have also Simon Chassin.
Hello everyone, I'm Simon Chassin. I'm representing Innovacom. We are French. We are the e-health branch of Orange Group. I'm very happy to be here today.
Emmanuel Masson.
It's more COVID. Emmanuel Masson, I'm the CEO of Clinea. Clinea is the French branch of Orpea Group, and I'm also the executive vice president of the group in charge of the development and the strategy.
Thank you very much. Sébastien Duré.
Hello everyone, I'm Sébastien Duré, co-founder and managing director of Open, a French technology company specialized in e-health and patient journey.
Thank you so much. And Yannick Lucas.
Hello, I'm Yannick Lucas. I'm Director of International Relations of Trade Differences, the French Federation of Non-Profit Health Insurance.
Thank you so much. So this morning, sorry, so I think our first intervenant will be IA Life Designer. Are you with us?
Yeah, we are with you. Elodie, so I present myself. I'm Mahfoud Benasser, architect partner from AIA, Life Designers, and I will make presentation today with Simon. You can introduce Otto.
Hello, I'm Simon Tudos, architect in AI Designers and partners in the group.
Thank you very much.
Okay. C'est pour nous, Elodie, on will start?
Oui.
Okay, thank you. So, first, we are sorry because I have provided to be with you, but as you know, the sanitary reasons, this stopped my trip. I have COVID last week, so I could not be with you. And second thing, we have prepared one presentation, a big presentation for this subject, but I understand we have only 10 minutes, and to take this time, we have reduced our presentation. The title of this presentation we have is Toward Health Urban Planning. As you see, tu peux rester juste dans la première slide. So the picture you see is it's the page of our book produced by our foundation, and all our work now we base it off this research that our foundation do now since 10 years we started this research. Okay, you can go to the second. This is the content. We can go ahead because so much. Vous pouvez passer à l'autre. So I introduced AIA. AIA, like designer, is created in 1964 by 2 engineers and 2 architects. For this, we have the name AIA, Architect and Engineer Associated, and now we call it like designers. So we have an experience now since 56 years ago. We work on this subject of project in sanitary, but not only in a hospital or clinic. Our company now, we have 150 employees, and we have 40 sites in France. Major is in France, and we have some sites in Luxembourg, Switzerland, and China. But we work. We have a lot of projects also on all over the world. And the major of our entreprise, we have AIA Architect, take all the architects in this company, and we have AIA Engineer, AIA Engineering, and also AIA Management, all the people that they work in the site and also follow the client. And the fourth is AIA Environment. This is what our subject is. AIA, they work all for the environment, and we follow also all architect and engineer on our work. And also AIA Territoire is for urban. They work for the urban. So our IDN, as we design together, project where health and well-being are the heart of our commitment. This, you can go to this, for this, it's now 2-3 years AIA designers committed for the future, and we give another thing that we said that we go from shared architecture to the committed architecture. For this, we have take 4 big committed. The first is to monitor the global carbon territory to comply with the Paris Agreement. It means that we monitor this trajectory not only on our project, but also for our life to every day for all salaries. So we try to monitor which transport you use, or car, or bus, or bicycle. So we calculate all of it. So it's a big committed that we try to do now. Since 2 years we have started to do that. The second is to promote the health architecture in all our projects. So all our projects that we make the relation. No, we are not in this slide. Okay. So also we do the environment entry in all our projects, as that the client don't make this in this committed, but I committed that we try to apply all the environment on our project. So for this we have based for the foundation work, and I give to Simon to speak about this.
Okay, quickly. So we have set up a foundation more than 10 years ago, as Matthew was saying, and it's focusing on research of the relationship between architecture, health, and environment. This theme was set up a few years ago around the paradox that while the world population is continuously rising, proportion of rural population is becoming lower than the urban population, and at the same time, life expectancy in urban areas appears to be higher than the rural areas. So the mission of our foundation has been established to research what are the determinants that life expectancy would be higher in the city rather than countryside. Next slide. Next, please. Elodie, vous passez à l'autre. Yeah. So our foundation has published several books and did some many workshops in Paris, but in many different cities, and published books in France and in China. Next, please. Next slide. Yes, thanks. And last year we had we set up an exhibition in Venice in the Biennale of Architecture, and this exhibition was called "What Binds Us." Next, please. So this was to present the research of our foundation. It's an exploration between interaction of health determinants and our living environment. Next. So our instant health results from the influence of different factors which effects accumulate throughout life. These are the determinants of health. Next. And according to recent studies, we realized that only 30% of the health status is determined by genetics and medical care. Therefore, the living environment is preponderant in the health. It's about 70% of health determinants are given by our environment. Therefore, it's a great lever in terms of prevention and health promotion. That's why we set up this tool to promote and to put the health in the center of our projects. Next. Okay, maybe next, because we are lack of time. So we applied this logic in different scales, different projects. This is a project in Hangzhou, where we have a comprehensive program with hospital, research tower, education, exhibition, library, senior living, expert and student housing. This is a mixity of users that allowed us to apply this health approach, global health approach. Next. This is a project in Monaco. It's the Princesse de Grasse of Monaco. It's next. Sorry.
You go so fast now. You stay in Monaco. It's possible. You go back.
Yes.
This slide.
Yeah. Okay. So in this project, maybe next slide, please. Thank you. In this project, we apply this approach for different sensorial items for the users, such as the earth. So that's the way the building is attached to the cliff gives the feeling of the environment with a observing platform on the landscape, as well as the sunshine with the bioclimatic skin that allows natural light in all the areas, indoor areas of the hospital, as well as the water, with also a continuous relationship to the sea from the building, and the air, because the wind is very present in Monaco, and that's the base of the concept of the project.
Next. This in the same also I think we have no time. I be quickly. This is the project in Morocco. We are in stage study. It's a big hospital, 200,000 square meter, and we apply also all of this work we do with the foundation and our company, bioclimatic skin, garden in the on the facade, and also collect water, running water, so we can go next if we want. We have some. This is all the work we do with IA environment, and we have all subject link it with the environment, and we apply in our project light, solar, wind, all of this subject. Next. So we have some picture. We see, for example, if in each level we have this balcony for the patient, that we will have a good view on the city, and we think that the space also we have a link with the healthy. Another another example is in China, in Shenzhen. As you see, another project, and we have also applied all of this subject of environment in the project, the garden in the terrace. Next, you can see in the project. So we have made the garden in on the low level, but also on the high level, and for each level we found in the unit ward this space opening in on the environment for the patient, that we will have good space for them. But we think that they help him for this healthy. Next. This project is in Reunion Island, and here we have, I think, is one of the big projects that we have do all items of the environment, design biophily, design active, and design sensorial, as used in this project. As you see, the big garden, and also we have do and apply this natural ventilation. So in this project now, 7 months on the year, they don't use mechanic ventilation. We do only the natural ventilation. So, and you see some picture. This is another project in Tours. Also, as you see, we try to apply all what the research of our foundation in the garden for road for the patient, and also to have a sweet space, protection of solar sun.
Thank
Next.
you so much. I think we should soon.
This is another example. Is the project in Caen. Here we have used it for the garden, also inside the project. As you see, we try to have a good space inside the project for the patient to follow the patient between the lobby as the operating theater, and we try to reduce also the road to go as fast as possible. Like that, that the patient be no stress to go to do medical care. Next.
Yes, thank you so much for your presentation. I think
all subject, as you see, and Simon. Another last project is not in. This is another project in Paris. This is the Institut Pasteur. As you see how we work, that we try to find all the area that the patient can make protection for sun, make wind, and for this we finished to design all the garden around this project, existing project. Next.
Yeah. Do you hear me?
Yes.
Yes, I think we should.
The last one is the Reunion Island. If you go.
Just for the last project is a different type of project. Is a hospital in La Réunion, which is being built, and will be the largest airport with natural ventilation to be built so far. These are the natural ventilation studies. Thank you very much.
Thank you.
It was a bit long.
Thank you so much.
Sorry, we have to do it quickly as possible. I hope you enjoy our presentation.
Thank you very much.
Nous avons fini, Elodie.
Thank you so much. So now I would like to ask Emmanuel Masson, who is the CEO of OPIA, what do you think in terms of urban planning, and how healthcare did impact establishment? How could you explain us?
Well, first of all, I would like to give you my vision of what I've seen during the last 25 years. I have the chance to work for PR for now 22 years, and I was before working for another acute surgery group for nearly 5 years, so I had the chance to see the evolution of healthcare in France, but from the last 10 years all over the world. In the country where RPA is based. So what my feeling is that we've seen something interesting during the last 20 years. First of all, we had all the main hospital in the center of the cities for many, many years since middle age or more, but we've seen that during the last 20 years there was a movement to get outside of the main cities for big hospitals, and which is interesting is to see that in the cities like Nantes, for example, but also Paris, you see that the main university hospital are leaving the center of the cities just to get into the suburbs or in the rings around the city, just to be able to get more space, but also more accessibility to see where they can get more space for their activity. Nantes is a good example. For example, the university hospital is in the center of the city, very difficult in terms of access.
C'est pas très fluide, le truc. Elodie, on n'entend pas, hein, nous.
You hear me? Shall I start again? I was in the middle age. If I go back, it will be very hard. Elodie, shall I continue or are we on mute? No? Okay, so I'll continue. So yes, what the feeling we have is that really it was interesting to see that acute activities, private clinic, private hospital, or the big hospital were in the center of the city, and that now they are getting outside of the city, which is absolutely the contrary for PA. And what we have now is that the nursing home, the rehabilitation centers, and the mental health clinic used to be in the suburbs or more outside of the city for rehabilitation centers. They were more in the mountain or far away from the main cities for the beginning during the 50s and later. But now they are getting back in the center of the city. So we see a movement which is absolutely the contrary. We need to have those activities in the center of the city and big hospital outside of the city. It's really reversed. And what you see here for PA, you see that two nursing homes which are absolutely inside the city. One is between small houses, and the other one is in a big condominium in Rio, in São Paulo. And both, and the first one in the center of the city is in Uruguay. The other one is in Brazil, and you see that we are in the center. We are not outside. We are just integrated to the main activities, which is very important. And what we see that's now this movement of the healthcare has to be adapted to these needs from the population. So when we talk about nursing home, when we talk about rehabilitation, when we talk about assisted living, we talk about daycares, they are back in the city. And those services are now close to the needs of the population. And I think that this movement has to be continued and supported by all the home care, assisted living, and also the technology like telemedicine. Healthcare is coming back in the center of the city, but they are entering the houses of the patient. So this is really the main is that you keep the big platform, very technical platform outside of the city with the big hospital, with the big access, and what is coming back in the city is telemedicine and the smaller services, the more closer to the patient, and even though going inside the houses. So that's the first thing I would like to underline. On the next slide, you can see that Orpea has now a footprint all over Europe and also in different countries, going from China to South America. We have a network of 23 countries, more than 1,200 facilities, nursing home, clinic, home care, assisted living. So we have this large portfolio which is very adapted to every kind of cares, but also which is very interesting for us in our experience, is that for the last 30 years of experience of Orpea, we have this track record of adapting the cares to of course, the medical, the layout, the design of our facilities to the medical project, but also to the culture, to the country, and which is absolutely very important, because going from one country to another, we have also to adapt for the rules, for mandatory but also for the patient. And really, this experience of Orpea is unique, probably for French group, but also all over the world. And I think that it's something which is a very strong experience, which has to be also give more information about and share this experience. When we talk about experience, for us and for Orpea, what is important is really that for the last 30 years, as I said, Orpea has adapted its model. Dr. Marian, the founder of Orpea, he was a doctor, but he was a psychiatrist, and his vision when he created the group was to really adapt the design and the layout of the building with the medical project. 30 years ago, for nursing home, there was no adapted layout for Alzheimer patient, for example, and the nursing home were very, very unhuman in terms of places to work, to live for the patient. What we have now in Orpea is really to be able to adapt this model, as I said, to the culture, to the local habits, and to the country. We have also now the new generation of those projects. Of course, they continue to be adapted to the patient and the needs, but also we need to have green buildings now because of the rules, but it's absolutely also the part of Orpea to be part of this new generation of buildings. So you see a lot of natural light, you see the use of natural wood and all what we can use for this. The layout is also very important for to be less energy, to be also adapted for the HR, to have also some CSR policy very implanted. For example, in Ireland, we need to have some housing for the staff, but we have also this new policy to integrate into mixed buildings. And the future will be also to adapt our buildings not only to our activity, but also for mixed buildings in which you can find services. In Switzerland, we have the restaurants in our assisted living which are open for the public, so people are coming for lunch and mixed with our residents. We have kindergartens in our nursing home in Austria. We have physio center in Germany mixed with the nursing home. And we mixed also the generation in France between elderly care and younger one. We have also the culture. We can also integrate culture in order to be adapted to the local habits. And of course, we work with our architects. Each time there are architects from the country, so they have the local habits. So, for example, here in the GCC, we're working with Unanim architect, and it's very important because they are from Bahrain and they know the local habits. And for us, it's a very important fact that we have this partnership. So to conclude, we know that the future of the medical architecture is really based on the medical project, of course, but to mix the medical project with a place where people live and work. That's the next slide. And it's very important that living spaces, a great place to work, as where the people can be able to continue to enjoy life, and we have to remember that architecture, places where people are going to continue to live for the end of their life, or for some moments of their life which is difficult, for example, rehabilitation and mental health, they need to feel well in the architecture and in this new building. So it's very important for us that these places are totally integrated in the system of urban organization, but also healthcare. Thank you.
Thank you so much, Emmanuel, for all this insight. To go on, I would like to introduce Simon Chassin from Innovacom, that will talk about also urbanization and digital healthcare.
Thank you, Joanna. I don't have any slides, so don't worry, Joanna. When I've been asked to talk to this roundtable, I immediately think about all issues we are facing every day to provide continuity of information between the hospital and the city. This is really the topic I would like to address today, and I would organize my talk into two parts. First, I will do a small assessment very quickly, and then I will explain you how we can achieve this target of continuity of information between the hospital and the city. So first of all, let's do a small assessment. Like you all knows, every healthcare providers are not talking together. We know that from national point of view, but also in the city, when you go to the hospital, then you need to go back to your doctor in the city, to your GP. And very often, your doctor doesn't have your medical report from the hospital. Why? This is a good question, because actually this report is sent by post, so it takes a bit of time, and usually the patient is going before to his doctor to have the follow-up on the care process. There is another case, very important also, and I think Emmanuel is quite aware of that, when it's about elderly people. The medical file is quite big, and each time the son who is taking care of the elderly people needs to go to a healthcare facility, he needs to bring with him all the medical report and explain again and again the medical context of his father or mother. So this is really an issue. There is no continuity of information between the hospital and the rest of the city. So the target for that is to implement and to develop what we call the integrated care. The World of Health is giving a small definition of that. I will just try to mention that. Integrated care is a concept of bringing together inputs, delivery, management, and organizations. Integration is a means to improve service in relation to access, quality, user satisfaction, and efficiency. This is a wide definition, but I think it's a good summary that we need to involve all healthcare providers from the hospitals, but also from the city. And the target for that is to improve the quality of care and the patient management in general. So how at Orange and Innovacom we can help to achieve this target? There is many options to achieve that target. First of all, the hospitals need to be connected to the city, and the first thing is to be able to deliver some network connection. Of course, the hospital need to be connected to the network in order to exchange information with the city, with the GP in the city. So this is the first thing. And if you want your healthcare professionals and your patients, your citizens in general, to interact with the hospital, you need to provide them from some mobile equipment first, but also a network, mobile network, to allow them to interact with the hospitals. Another option, of course, is to improve the IT infrastructure of the hospital. And you all know that nowadays it's very there is a lot of cost by building by our own your IT data center. So this is why we can see that the cloud offering is increasing a lot. And at Orange, we have a lot of solution to provide to the market thanks to the Orange Cloud for Business offering. In the healthcare, medical information are very important and very valuable. This is why cybersecurity is also a very important stake. And at Orange Cyber Defense, there is a lot of skills and expertise around that to provide the most effective security around the medical information. One of the baseline of Orange Group is network digital native. So part of the group offering, there is a lot of people working every day in the digital space. We at Innovacom are part of this organization. Smart City is also one of the big strategic points from Orange Group. So they are providing a mobile application called My City in My Pocket that allow the citizens to interact with the city for administrative procedure, for example. The idea is to digitalize this aspect, but also to provide some data and artificial intelligence, to the people in charge at the city, for example, to make sure that there will be no flooding, so they are able to deliver some IoT solution that will prevent from that. On the Innovacom side, so we are the branch in charge of e-health at Orange. We are a specialist in information sharing among the continuity of care. So this topic of continuity of information is really something important for us. And we have been working in that topic for many years. And we can still see that there is a lot of things to achieve. So first of all, data exchange and sharing is one of the key success of achieving this continuity of information. So being able to send information to the GP in the city, being able to send a COVID test result to the national screening system, interacting with social insurance also is very important to make sure that the care will be paid, of course. So this is one thing. The other one is collaboration, how to include the GP in the city into the medical process. I'm saying GP, but there is also other healthcare providers like Opera that they need to be involved also in the care process. And for that, we can support the implementation of this digital solution like patient portal, like healthcare provider portal that will allow a most effective collaboration among all the care process. For example, there is a very interesting case that is the cancer treatment. You need to involve different specialists from different locations, and they need to come every week at the hospital to make sure that every patient are treated with the right specialist. This kind of tumor board, this is what we call that, that could be digitalized, and it's easier for everyone to connect to a virtual room and address every cases in the most effective way. So this is something we could support at Innovacom. Just a last example, what we provided recently, we've been part of the National Information System for COVID screening. So it means that every day we collect all COVID results from all over the France. We centralize this information into one single database that is used then afterwards by anti-COVID application for contact tracing, but also for everyday statistics that you hear every day. So in a conclusion, I would say that what are the benefits of this integrated care? This is improving the quality of care, decreasing the costs, increasing the efficiency. And we can see also a shift to what we call a value-based healthcare, where we put the patient in the middle of the process. And when you think about this concept, it's making sense really. at the end, the patient is the most important things. So when you have achieved this continuity of information, you can think about taking care of digitalizing the patient journey. And I think I will end on to Sébastien.
Yes, thank you very much, Simon. So Sébastien, yeah, after the infrastructure, you can go further also to plan differently for patients.
Exactly. Thank you, Joanna. Thank you, Simon. When we talk about urbanization, and if we think about the definition of urbanization, one definition could be organization and development in urban spaces. And in fact, when you talk about organization, in order to be efficient, you need to talk about processes. And in healthcare, around the city, hospitals, and patients, and GP and all practitioners in general, you have two kinds of processes. One between medical operators and professionals, like Simon presented before, which is very important, and where we need to be able to provide more offers and more solutions to be more efficient in any ways. And the other one is mainly concerning the patient and the way that patient interacts all along his pathway. It's a quite complex process, and when the patient take part in them, you need to take into account the logic of cost, logic of efficiency, and also a logic of autonomy. And I insist on this last point, autonomy, because it's a very important one, which regularly comes up in all patient experience questionnaires around all countries of the world when you talk about what need to be improved for patients. And this last part can be only done through digital. And I think that we all need to improve the way we bring more digital into all processes in order to be able to improve the satisfaction of patients, but also the safety and at the end all the efficiency of these processes. The development of notions of patient portal, or what we call patient apps, is quite strong in Europe and in France in particular. A lot of French technological companies work since several years on these topics and are quite ahead on this subject. And there is two main reasons for that. The first one is that the French system, hospital system, is quite complex. And in order to deal with this complexity, a lot of people started to work on how digital could improve and facilitate and simplify the global system. The other reason why there is a strong focus on this subject in France is that the French government, in particular through the DNS, which is the Digital Health Division of the Ministry of Health, is strongly pushing all companies to work on that topics, because it's very important at a national wide range, and it has a very big impact. And I think that at the moment French technical companies are quite ahead on this topic and are able to work everywhere to bring all that has been done into France in particular. Another important point when talking about urbanization and digitalization is to realize that the patient's journey begins long before he enters the hospital and doesn't stop when he leaves the hospitals. In fact, when you have to go to the hospital, you have first to take an appointment, you have to prepare your trip and to choose the way to go to the medical center, which can be by your own car, you can take public transportation, you can book specific medical transport. When you have chosen your transport mode, you know also to make pre-admission, prepare some administrative questionnaires, prepare payment, prepare commitment, and consentment in general. So you have a lot of things to do on the administrative way. You have also to take in charge and to prepare all the hospitality offer you will have during your hospitalization. You need to choose if you want to have a private room, or in some countries there are specific comfort offers that need to be booked by the patient. For example, entertainment, multimedia, but also a suite for accompanying people, for example. And that there are a lot of things to do before the hospitalization during the pathway. You also need to prepare for, on a medical point of view. In general, you have to prepare some medical questionnaires to stop some treatments and to ensure that you're ready to go to the hospital or to go to surgery, for example. And after that, you also need to think about returning home. When you will finish your hospitalization, you will need to come back. If, for example, if you go by car into the hospital, you might not be able to go back with your own car. You need to prepare that to ensure that we have the good transportation system. You will also need some nurses at home for home care. You may need to loan medical equipment or to buy medication to be taken after the discharge. So it's very important to help the patient to anticipate these elements, to improve efficiency, and to avoid for the patient to do everything at the last time and enjoy quite badly. So it's very important because in Europe and in the world in general, there has been a lot of improvements into medical techniques. But when you go back very early, in particular with the development of ambulatory surgery and ambulatory services in general, you need a greater medical monitoring at home. And here again, all digital tools have also place to ensure the safety at home at this moment. If I come back to a specific and quick example on how urbanization and digitalization are cross-linked, I will come back to the subject of transport. Where we can highlight a strong issue between the constraints of urbanization and the location of the health centers. As Emmanuel presented a long time ago, acute care were mainly into city centers, and progressively they go to the suburbs. In any case, you have specific issue, in particular with the issue with the transport. When you are in downtown, it's very complicated to go there and to have a car access, to park your car, etc. But outside the cities, you have an easier car access, but you have less public transport. It's sometimes a bit further away from your home. So in any case, you have to take into account the constraints of the place of the hospitals. And if we take an a quick example on the ambulatory surgery, in general, the efficiency of the ambulatory surgery depends on the fact that the patient are on time into the operating room. However, daily operating and surgery program are very regularly disrupted because patients are late. And they are late, for example, because they had a lot of traffic on the road, and it's quite complex to be on time at this moment. And this is where, for example, digital can help to improve this process. For sure, we have all digital solutions on our own devices, like Waze or Google Maps, to anticipate and to see that, okay, it will take 30 minutes to go to the hospital. But this kind of the digital solution can be included and integrated into specific medical apps and patient apps, in order to be able, for example, to give back this information to the hospital. Because the most important thing for nurses and into the surgery in general is to have the information as soon as possible. Because if the hospital staff knows you are late at the moment you present to the admission of the hospital, it's too late, in fact. You need to have the information at start. If it's possible to give the information when the patient leaves home, and he say, okay, he lives there, it will take more than 30 minutes to come, okay, we will not be able to achieve to come at the good time, at the right time. So we can reschedule his operation a bit later and prepare the operating room, for another operation, for example. So this is a very quick example, but which shows that with the constraints of urbanization and the way that the processes are done with the patient, a digital solution can help a lot to bring more efficiency and more safety for the patient at the end. So, and at the end, the satisfaction of the patient also. So.
Thank you so much, Sébastien. Talking about urbanization and patient, Yannick Lucas from FNMF, you will introduce us a specific subject, microsystem of health.
Yes, thank you. I would like to speak about a project managed by French Healthcare. And the idea is how we can provide primary healthcare in the center of a city, and mainly for population who don't have access, first to primary health care and second to health insurance. So it's mainly for poor country where you don't have a social security system. So the beginning, the start point was the idea of the definition of health system. So we're waiting for the slide. So this was the beginning. The idea is what is a healthcare system? The healthcare system, it's we have seen that at the beginning with the idea that healthcare was only a part of how the population is healthy. First, you have an economic and social context, and after that, you have healthcare resources and activities we can provide healthcare, and when we're speaking about that, we have first activities and the staff we can manage these activities. And you have also the idea of an health system performance. The health system performance, it's first quality of healthcare, second access and cost. And what we are working, and we're working on both sides. First, we are trying to provide healthcare resources in the center of the city, and also to provide access, and mainly financial access to these activities. And this can give an health status. Second slide, please. What we're talking about, if we are speaking about healthcare system, we are mainly speaking about 3 levels in the healthcare system. Primary healthcare, which are mainly provided by the community health center or GP. Secondary healthcare with mainly community hospital, and tertiary healthcare, we are mainly specialty institute. And the idea was only to work on the first level, which means we are only speaking about primary healthcare center, because there is a problem of cost, and mainly the hospital costs are more expensive and more difficult to provide in poor country with this kind of microsystem. The idea of the microsystem is 2 pillars. First, to create a primary healthcare center, and we're speaking about mutualist primary healthcare center, which means a community-based healthcare center. We can provide GP consultation, some specialist consultation, and also some what we call light hospitalization, mainly for short-term treatment, like of palliatism, or also forced birth. And the second idea, it's when we have in some countries some primary healthcare centers, the problem is the population, they don't have the money to pay the care. And so the idea is to mix the primary healthcare center with a mutual, a non-profit health insurance. This mutual will help to first pay for the cost, and also the idea to mutualize the cost, so to provide access for everyone. So the principle of the mutual, and we try to apply this principle both to the healthcare center and to the insurance system. Next slide, please. Are based on some mutualist values, which are democracy, solidarity, non-profit, and common ownership of assets. And this kind of principle are very efficient in countries where you don't have some efficient public health system. And that was the idea to create, beginning from a local roots, beginning from the community, a small health system. We will provide primary health care to the population of a much smaller area. It can be a village, it can be a district of a city. And the idea, when we're speaking about urbanism, and it's to provide services, healthcare services in the heart of the city. Because it's all important when you are speaking about urban planning to think that people, they will need healthcare services close to their home. And the last slide will be a short presentation of how everything is working. The center is a mutualist health center, so the primary healthcare centers. You have a mutual. The mutual, we can help to provide the payment for the care. Of course, you have some members. Some members will receive health care for the mutualist health centers. They have to pay membership fees to the mutual. And the idea is to work with, to create this center, first with French hospitals and French services where we can help to give some expertise in the construction of the center. And the idea also is to work with local builders, because we think that we must also use the local capabilities of the local builders, and the idea to try to provide also some funding to help to kinds of mutual health center. So the idea is to create at a local level a small health center to provide a primary healthcare system to the communities. Thank you.
Thank you so much, Yannick, for explaining us. Now to conclude the last intervention, Michael Lozano from Tesalis will introduce us to also biomedical waste and specific issues on environmental footprint. Michael? Michael, est-ce que tu es avec nous?
Should be providing healthcare and providing treatment to the patients, and should take care of not making people sick. So they really need to focus on the environmental footprint that they generate, particularly in those urban spaces. So this issue is based on three main topics. So the healthcare facilities in the urban spaces will have issues related to traffic and parking. Of the patients that are going to the healthcare facilities, of the medical staff, which is going also to work and to take care of the patients, including also the external medical staff, like, for example, the ambulances or the external nurses and people like that. And also all the suppliers, which are going to be delivering all the different staff for the healthcare facility to work. On the second issue is everything which is related to the consumption of supplies, which I have called inputs. This is regarding water consumption, energy consumption, including electricity, medical gases, fuel, everything which is required to supply the energy to the hospitals. And then we have everything which is related to drugs and medical supplies. And we know that medical supplies is also a big issue for the environment, because a lot of the medical supplies which are used in the healthcare facilities today are consumables which need to be taken care of. And then finally, there is what I call the outputs, which things that the hospital generates and impact the environment, which are related to waste, wastewater, and the chemicals which are used in the healthcare facilities. Everything which is related to CO2 generation, which would include the heating of the hospital, but also all the vehicles which are used in the hospital and around the hospital. And finally, medical waste treatment, which is really a hot topic, especially now that we have experienced since 2 years a very large increase in medical waste generation due to the COVID-19 pandemic. Some of the countries, they have multiplied by 4 the quantity of medical waste that has been generated, and this has a significant impact on the environment. If we can move to the next slide, please. So basically, what can we do in order to mitigate? What are the things that we can do in order to mitigate all these impacts that we have identified? Can you move to the next slide, please?
Yeah, I'm sorry, Michael. Technique?
Yeah. Okay, anyway, doesn't matter. So basically, on the first topic, which is related to traffic and parking, some of things have already been touched upon in the previous discussions. One of the things is, for example, optimizing the number of times that the patient has to go to the hospital. So with digitalization of the patient path, is one of the things that can avoid the patient to go to the hospital too often. Telemedicine could be also some of the options to reduce the quantity of people going to the hospital. Of course, everything which is around, we call it in French, I like this word, that is mobility douce, like a sweet or a soft mobility. So having access to public transportation and having access to bikes or electric scooters or whatever. And then two important points as well, which are related, for example, to the short circuits. So the hospital should be considering the use of short circuits for the suppliers, for example, for the food or for the any kind of supplier. And also, like for example, the internalization of some of the activities. We have seen in the last 20 years that a lot of the healthcare facilities are subcontracting a lot of the functions. For example, catering, for example, laundry, for example, sterilization of instruments, okay? And not to mention hospital waste management. So all this externalization makes a lot of traffic because we need to bring all those supplies to the hospital. So some of the hospitals have started the process of re-internalization of some of the functions. For example, one of the private clinics in the south of France, in Toulouse, they have decided to re-internalize all the kitchen, all the catering, taking care and then providing the food from the local providers. In this way, they are really minimizing the footprint of CO2 generated by the catering activities. Okay. In regards to the consumption of supplies, which is the inputs, I would say that one of the important things is having an eco-design of the hospitals. We have seen in the previous presentation by AIA that it's very important that the hospitals and the healthcare facilities are designed from scratch in order to be much more respectful of the environment. Was a very, very good examples over there. Then we also need to look at the use of renewable energies. Some of the hospitals in the center of France, they have decided to put solar panels on the parking lots, so using the energy of the solar panels in order to be minimizing the energy impact that they have. And then finally, for example, using green vehicles should be one of the possibilities. And then if we go to the third source of impact on the environment, we can talk about the waste and water, wastewater and chemicals which are generated, which need to be really under control, because it's a very important source of pollution in the healthcare facilities. What I would like to touch upon is one specific example on the way that we can reduce the outputs of the hospital, which is waste management. Basically, I think we have a video here, so maybe we can go ahead if you can display the video. It's just a 2-minute video, and then I will come back to that.
Thank you very much, Michael. I will invite you to conclude as our section is going to the end. Michael?
Sorry?
If you have one last word.
Yeah, sorry. So, as shown in this short video, basically the idea that our company is making a system which is enabling to treat the medical waste on site as opposed to transporting it and incinerating it. And this has a significant impact in CO2 generation. So this is what I wanted to share with you, just to conclude the presentation, say, okay, healthcare facilities really need to take care of the environmental footprint, particularly in urban spaces. Thank you very much.
Thank you, Michael. I would like to address a huge thank you to all our intervenants this morning. Thank you very much.
Hi everyone, thank you for being here for this conference organized by French Healthcare Association. I'm Cécile, I will be the moderator of this session. So today we will introduce the French healthcare system and treatment opportunities for international patients. So we have a lot of very interesting speakers, physically and remotely. Remotely we have Jean-François Gendron from French Healthcare Association and Adrien Rebaud from Billy. And maybe I will let you introduce yourself, gentlemen.
Thank you, Cécile. I am Guillaume Huard, CEO of Orpea Middle East.
Thank you, Cécile. I'm Jean-Patrick Lajonchère, CEO of Hospital Group Paris Saint-Joseph in France.
Hello, everyone. I'm Lambert Montevecchi. I'm acting as a sort of ambassador for the Centre François Baclès in Normandy.
Hello everybody, my name is Jérôme Souastier and I'm CEO of C3 Medical.
Thank you. So before starting, I would like to have a few words of introduction. As you may know, the French healthcare system is one of the most efficient in the world. Its social security system covers 76.8% of health expenditure. And the good news is that international patients have the opportunity to benefit from this system too. Actually, initiatives have been put in place to give as many people as possible access to excellent French care. And during this conference, several speakers will discuss these opportunities for access to care. So first, I'm very pleased to welcome Jean-François Gendron, who are the president of the French Healthcare Association. And he will present the French Hospital Quality Label and My French Hospital website, two French quality standards. I don't know if you can hear us, Jean-François.
Yeah, very well.
Great. So I leave you the floor.
Okay, so thank you, and I'm very happy to introduce this conference because I think that travel to France for medical reasons will again be widely possible. And we expect, of course, to receive more and more medical travelers in the coming months. So, why France? Because French medicine combines therapeutic and technological innovations and a strong network of specialists in every field of medicine. This is especially true for cancer treatment, which is the first reason for medical travel in France, because we have leading cancer centers, for example, and patients also travel to France to consult experts in cardiology, urology, proctology, internal medicine, diabetology, and vascular surgery, and so on. And the French offer is very large. So you speak about the French medicality. Beyond the excellence of medical treatment, French healthcare facilities are also fully organized and dedicated to answer to international patient needs and to guarantee high-quality services such as bespoke reception, catering to special demands, and efficient communication. The French Hospital Quality Label was designed. It identifies institutions that meet the highest quality standards, like, for example, the American Hospital or Saint-Joseph Institute. And Healthcare Association has also launched a dedicated website, myfrenchhospital.com, search engine intended for foreign patients seeking a hospital in France. Thank you.
Thank you, Jean-François. So now let's move to another intervention. Guillaume, you are CEO of Orpea Middle East, and you will present the French healthcare system with a Middle East prism.
Thank you so much. would like to share some slides with you. So first of all, let's keep in mind that France is a key player in global healthcare. Can I get the slide?
Yeah, we don't have the slide on this. No, we just can see ourselves, but not the slide. It's okay on the big screen, but for us, it's not the slide. Okay,
yeah. Perfect.
Thank you.
So France is a leading player in healthcare worldwide, and we're gonna focus on the advantages of the healthcare system. As you have mentioned, Cécile, we are a country with a healthcare system recognized about OECD nations for access to healthcare on the whole territory. Second point I wanted to emphasize is the excellent training that is provided for healthcare professionals and the recognition of the high level of expertise. Healthcare cannot go without a strong research environment, and of course there is a cutting-edge research in numerous fields that are fully internationally recognized. Healthcare and research cannot go without a pharmaceutical industry, and we have also this strong, high-performing pharmaceutical industry fully recognized also with our pharma leaders. And of course, we are talking also about innovation. Care cannot be developed with a high innovation, and a company like Orpea Group has fully integrated the innovation process in all aspects of the care given in our facilities. And finally, we need a strong support, not only from the big groups, but also a strong development at the SME level, small and medium companies, to make sure that an idea developed in a startup can be further developed and profit to the global population. So what I would like now to emphasize are four topics: qualifying the healthcare system, excellence, universalism, efficiency, and science-based progress. Excellence, we find it in the big network of our public and private hospitals, with all the bridges that the legislation has brought between private and public hospitals, from the university hospitals to the private hospitals, and with a strong transfer of knowledge from the university hospitals to all type of facility dedicated to the healthcare and to the care given to the population. Universalism is the second word I wanted to emphasize on, because we are not treating the patients only based on their revenue, but France healthcare system is providing care for any type of person living on the territory. Finally, before going to science-based progress, I wanted to emphasize on the efficiency of the system. If in some hospitals, in some part of the world, you are first asked your credit card when you enter the facility, or you are first given treatment or exams that you don't need, in France, we will always target the dedicated exams, medical imaging exams, biological exams that are required to investigate and build the diagnosis of the patient. And finally, science-based progress, based on the strong integration of medicine and research. Our team are able to make evolve the knowledge on each disease and pathology, and bring the last science-based progress for the patient. And finally, a very important topic, we are providing a patient-centered organization. It's not only a direct link between one patient and one doctor, but the whole Health Allied team is fully involved to make sure that the patient is going to be given the appropriate care. So this is something also that wanted to, for me, that really qualifying the French healthcare system. This is this patient-centered organization. I've given you, as a reminder, we have talked about the integration of research and medicine, and of course I wanted to show you the list of the 13 French Nobel Prize for Physiology, and this is supported by a long tradition of the research organization present in the hospital. A university hospital is not only a hospital, but this is also a research center and an academic center with the university. And from my experience in the region and in France, I think this is a unique kind of system that is, to my opinion, something that we have to be really proud of. We have talked about the Nobel Prize. I wanted to emphasize also the strong support to innovative treatments. Innovative treatments are also developed in the university hospitals, but also in some private hospitals that are fully integrating this aspect. We will talk, of course, of the cancer institutes and the specification of the cancer institute in the healthcare field in France. So we got a lot of first of a kind. First of a kind is what is gonna show the dynamic of innovative treatments in France. And from the identification of the genetic cause of Down syndrome at Necker Hospital in 1958, till the first complete clinical remission for a patient with a sickle cell disease by gene therapy, we show that there is a huge dynamic in the medical field, in the surgical field also, developed in our country. I would like to now emphasize the challenge. France has this amazing healthcare system. We are in a context of competitivity with a lot of countries in Europe that also want to develop medical tourism to attract some rich patients from abroad to treat them in the country. And I wanted to emphasize the creation of this website that Jean-François Gendron has mentioned, My French Hospital, mainly presenting the activities of some non-for-profit private hospitals in Paris. But this website, to my opinion, is key to present our expertise. We have, it was mentioned in the last session, we have a strong healthcare system, but we have also a very complicated healthcare system. We have 4 kinds of hospitals: the public hospitals, the cancer institutes, the non-for-profit private hospital, and the for-profit private hospitals. All of them are able to welcome and treat the patients in their French facilities, but from abroad it's not easy to identify which hospital for which pathology. Someone can be key on this topic, and I'm very happy to say hello to Dr. Pierre Oupicchian. Pierre Oupicchian is the regional counselor for health in the Middle East for the French embassies, and is able to connect every request received in our French embassies for treatment with the French hospitals. I was in this position before joining Orpea, and it was a daily part of our work to connect the GCC patients with the French hospitals, and with the support of the Ministry of Foreign Affairs and Ministry of Interior, also to get the visa for the patients who needs this treatment. We got a very successful approach for the Kuwaiti patients, for instance, going to a very famous Parisian Cancer Institute. The duration of the visa was only for 6 months, and based on a workshop that we got with the French Ministry of Foreign Affairs and French Ministry of Interior, we could enlarge the duration of the visa for the cancer patients going to France to 9 months. So giving them the possibility to get the whole treatment and not to have to go back to Kuwait to renew the touristic visa. So that was something, very important point, and that shows that also very important topic for me, that the different ministries in the French government have fully understood the dynamic that we want to develop on this topic. And finally, I wanted also to mention to be given the right hospital for the right treatment, that we have now a strong network of GCC alumni. France has decided to train some GCC Gulf doctors in the French residency program, and almost 400 of them are now back in their country after completing the residency program and the fellowship, and now are some ambassadors of the French healthcare system, and definitely we need them to be fully recognized by our embassies to also help us identify some patients that could be sent to France for dedicated treatment. So these are the points I wanted to express this morning, and we'll be happy to later answer some of your questions. Thank you very much.
Thank you, Guillaume. Yes, I have 2 questions for you. Quick question. Do the hospitals you have mentioned have some private conciergerie services, and do all French hospitals offer some individual rooms?
That's a very important point that you are mentioning. Depending of the nature of the hospital, I would say that the private hospitals, for-profit or non-for-profit, has fully understood that we cannot provide medical treatment to the Khaliji GCC patients, to the Gulf patients, without also bringing a high level of hospitality. And hospitality, to my opinion, is going to be really key to attract some GCC patients in the Parisian or French hospitals, because most of the time we have to keep in mind that one Gulf patients going to France for treatment will never go by themselves. They will always be accompanied by their families, and sometimes we just do not do not realize that when one patient is arriving, is going to be accompanied by 3 or 4 members of the family that are going to spend the whole duration of the treatment with the beloved patient. So this conciergerie service, of course, are not only useful, but we need them. We need them. We cannot do without them. And I think this is going to make the difference between a public hospital that is not using this type of service, that will not dedicate a single room for GCC patient. In the French public hospital, single room are dedicated for patients who need special care or for infectious patients. But this is not a hospitality rule, while in the private hospital it's easier to get a single room.
Okay, thank you. I had other questions, but I will keep them for the end, because I didn't tell you, but do not hesitate to write your question on the chat if you're following us remotely. And we will ask them at the end after all the interventions. And if you are with us physically, just raise your hand and we will let you talk. So now I'm very pleased to introduce Jean-Patrick Lajonchère. You are General Manager of Saint-Joseph Hospital in Paris, and you will present the care opportunities in France and in Saint-Joseph to illustrate the excellence of French care.
Thank you very much, and thank you to all are listening to today. So the Groupe Hospitalier Paris Saint-Joseph is located in Paris, in 14 area, and in Le Plessis-Robinson, just around Paris, for the second site. The Paris site is a generalist site with many pathology treated, and the Plessis-Robinson site is essentially cardiothoracic for adult and children center. So who are we? We are a private non-profit organization, very close with the French service public, and we have a multi-profile, top-quality healthcare. I say that. We have an emergency department that is open 24/7 a year, and we develop high-quality technical platform, especially in biology and microbiology, in anatomy pathologic and in imaging, with 4 MRI, 5 CT scanner, 1 TEP scan, and 2 gamma camera. We have 60 beds of intensive care and more with cardiologic intensive care and neurologic intensive care. And we have a very important multidisciplinary approach with center and specialized institutes. We have many international ranking distinctions, essentially from Newsweek, and you can see on the screen for 3 years, and included last year with COVID-19, where that was very difficult. So we are very distinguished on in general we are the 5th in France in the ranking of Newsweek, and with Marie Lanong we are the first on the cardiopediatrics by example. Some key figures: we host 90,000 patients a year. We have 800 beds. We have around 1,200 cancer treatment, 3,600 births a year, 67 heart and lung transplants, and 3,600 employees with 600 medical doctors. So with 600 medical doctors, we have really a very important expertise on every field of medicine. If I want to have a special spot on some specialties, on glaucoma and on proctology center, excuse me. We are first in France on these 2 specialties. We are since 2007. Oh, that's better. 2007, we are expert center in robotic surgery, especially on urology, but not enough. For example, on gynecology too. We are leader in laser technology. We are reference for cardiology and vascular treatment. And I haven't said that, but we have 15,000 treatments on cardiovascular a year. And we have an important research center with many awards in the international congresses and publications. And we are a top-level maternity unit, very well known on Paris. What do we provide? On congenital heart defect, and we will have a conference tomorrow for to develop this. Really, we are at the high level, international level. We are now the 5 expert centers, 2 in the world for surgical treatment on thromboembolic pulmonary hypertension. All this in Paris-Lannon Hospital. That's a very, very international, well-known center. What could we say? Sometimes new technologies is the support of very simple or very difficult problems. By example, the comprehension between the people, and it's not easy to speak all language in a medical unit, and we have developed a special application on smartphone, and that's called HostSpeech, and every language you have, maybe not the more, the less speak in the world, but every important language you have, you can be translated in France and speak with your nurse or with your medical doctors. And it's very, very well noted by patients. So only to have a special smile on research and innovation technologies, but I think we are able to do better when we speak medical pathologies. On teleconsultation services, our world-class physicians are trained to provide remote consultation, and we do. And we are entitled to deliver international prescription and medical certificates in accordance with local legislation. So this hospital is the newest of Paris. Our older renovation has been done for the older 10 years ago, and we have developed many gardens inside of the hospital, and so like a village, by example, and patients do like it very much because it's very, very pleasant. Not only medicine, but environment of medicine. So we have a multilingual team, French, English, Arabic. We deliver in less than 48 hours free, transparent and detailed quotation. We are responsible for international patients for the initial contact and examination of the medical file to the patient's discharge and the organization of any necessary post-operative care. And we offer medical checkups. So, here's my conclusion. Very thank you for your attention.
Thank you very much. I just have one question for you. You mentioned technological innovation as a leverage for improving the quality of international patients' care. Can you tell us a bit more about what answer do French technologies provide in this regard, except HostSpeech, because you already told that?
Yes, thank you. For now 5 years, we have developed artificial intelligence laboratory with more than 10 applications on cardiac, to understand exactly the cardiac flow, the blood flow, on neurology, on prevision of born in the maternity, and our teams work very hard on these artificial intelligence projects. It's an example in our imaging department. We are an expert center for General Electric with validating our MRI sequences of neurology, and we enhance the technology on this field.
Thank you. So now I leave the floor to Lambert Montevecchi. You are International Relation Advisor for the Centre François Baclès Cancer Center, and you will talk about the expertise of the Cancer Center for the care of international patients, particularly in proton therapy, but you will talk it much more better than me, so I will leave you the floor.
Okay, thank you very much. Well, first of all, I think we should be very grateful for French Healthcare and Business France and Pavilion France to host us here in this international arena in Dubai during Arab Health. So it's really a great honor, a great privilege to introduce you to the Centre François Baclès. So the Centre François Baclès is situated in Normandy in the city of Caen. And I also want to thank the two previous speakers for having told us about the excellence of the French healthcare system. We're relatively new players. The Centre François Baclès has hosted international patients in the past, but not many. And we're also, like Saint-Joseph, a non-profit hospital, which I think for patients traveling abroad to get treated is definitely a plus. And we're also part of Unicancer association, which I will spend some time describing because it's a rather unique organization. So we're a small hospital. There's about 1,000 employees, about 200 beds, so it's a very human size. We treat yearly about 28,000 patients. And there are 7,500 new cancer cases. So this hospital is entirely dedicated to cancer. I'll talk to you a bit about proton therapy and radiotherapy. We have 550 patients enrolled in clinical trials. Yes, I mentioned that already. We have about 1,000 staff. So there are two locations. This is the picture you see is the main building. And about 1.5 kilometers away, we have the proton therapy site, which I will talk about. We're also ranked in the top 100 specialty hospitals in the world by Newsweek in 2021. I won't spend a lot of time on this. French hospitals are already at very high standards with HAS and the different accreditation systems. But these are two accreditations that François Baclès has obtained, which are not so common. So OECI is a comprehensive cancer center, which means the patient has access in one location to just about everything he needs to treat his cancer. OZOMA is a less known accreditation centered on breast cancer. And again, it's looking for the excellence of care, of treatment in some very small details, actually, of how the woman coming to get treated will be handled by the nursing staff and by the doctors. So yes, I'd like to spend a few minutes talking about Unicancer. I don't think it's known enough around the world. So first, it's a very unique organization. It's made up of 18 cancer centers spread across the country. And they share a triple mission. Mission one, treatment of patients. And we're talking rather big numbers. I mean, France is not a huge country, but we're talking more than 500,000 patients per year, which is a considerable amount. I have numbers from 2018, so I don't have updated numbers, but it's almost 550,000. And in terms of consultations, it's more than 1 million. So we're talking a large organization spread out geographically. You can see on the slide all the main cities of France will have one. And as Guillaume explained, they're usually right across the street from a university hospital, which is interesting in terms of training and research. So Unicancer's mission is basically to fight cancer in these hospitals, to do research and to train doctors and health workers. I told you François Baclès has about 1,000 employees altogether. Unicancer is about 21,000 employees. The revenue is 2.5 billion euros. And what's really interesting, which is rarely mentioned, is that in terms of clinical trials in oncology, it's in the number of clinical trials, it's the number one in Europe. So we can be proud of that as well. And it's, I think, ranked 5th in the world in terms of publications in oncology. So they're very prestigious members in Unicancer, Gustave Roussy, Curie, and we are less known. We're the Centre François Baclès. We have a rather extraordinary radiotherapy department. I think it's 3rd or 4th in the country in terms of equipment. And we're also equipped with proton therapy, which I'll describe briefly. So what can we offer to foreign patients? Well, first of all, I think the human size. It's a small hospital, so the Centre François Baclès has always been recognized for its family feeling. It's a comprehensive cancer center, so it's fully equipped with all that is needed to cure different types of cancer. And it also has this very unique proton therapy site. There are only 3 sites in France, 1 in Paris, 1 in Nice, and 1 in Caen. And it's very surprising that cities like Lille or Bordeaux or Lyon don't have a proton therapy site. It's also a very new one. It was opened in 2019. It doesn't treat all types of cancers. There are some restrictions, medical and scientific restrictions. So I think apart from that, yes, I've said all this already. It's a state-of-the-art installation. We have doctors who are highly trained in proton therapy. We're looking to establish partnerships, international partnerships with other cancer centers around the world to exchange, not only in proton therapy, but in cancer, and possibly do research, combined research at an international level. I have a video which I will spare you, and last but not least, why should patients go to Normandy and not to Paris? Paris is probably better for shopping, but Normandy is a beautiful, extremely dynamic region, which is one of the reasons proton therapy ended up in Normandy and not in other regions. Also has a lot of UNESCO sites. It's very peaceful, so I would encourage any international patients seeking to get treatment to contact us. Thank you very much.
Thank you. And you said proton therapy expertise end up in Caen, and Nice and Paris, but not in other large cities like Lyon, Lille and Bordeaux. Why?
Oh, that's a really good question. I myself don't know. I think it's an enormous investment. I think it's in the region of 100 million euros. So in some countries, that's not a lot of money, but for the French healthcare system, that's a huge amount of money. So the region was heavily involved and financed the project. There was also a huge driver from the scientific side, because the Centre François Baclès is, like many of the Unicancer hospitals, on a kind of science park with the CHU, the university hospital across the street. I'm not sure of the numbers, but I think there's in excess of like 10,000 people, working on scientific projects. So it's a combination of political and academic and medical will to get this project to come to life. And there's one last thing I'd like to say about proton therapy. On the site, there's also a project for hadron therapy, which is even less common, much less common than proton therapy. And so in the medium term, we hope to be opening up also hadron therapy, both for, in the first instance, academic and scientific research, and then later for the treatment of patients with some of the most up-to-date technology in the world.
Good news. And another question, you talk about Unicancer, and apart for your membership to Unicancer network, do you have international cooperations agreements with other healthcare organizations in other countries?
Yes, it would really make no sense. You know, times have been difficult with COVID for medical travel, medical tourism, so it would make no sense to just aim for that. Plus, you know, as we've underlined before, we are non-profit hospitals, so we're not eager to get foreign patients to necessarily make more money. It's just to offer them this opportunity of treatment. So as part of the vision of the management team in Baclès, we want to establish international partnerships with other countries, with other healthcare institutions, and with other cancer centers. So recently, at the end of last year, we were very happy to be able to sign an agreement with Vietnam, for example. There's a large cancer hospital there, Hôpital K, and we've signed an MOU with them to, as I explained before, to exchange in terms of research, training, and treatment with Vietnam. We're also working with Romania, and we have a few other prospects. So yes, we do have other international cooperation agreements with other countries and other ministries of health, and we're hopeful to build some in this part of the world as well.
Okay, thank you. So now let me introduce you Jérôme Soistier. You are CEO of C3 Medical, which offers a global offer for insurance companies, mutual and companies aiming to improve the health of their policy holders or their employees while reducing their costs. So I'll leave you the floor.
Yes, good morning, everybody. So first of all, let me again thanks the French Healthcare Association for providing the opportunity to talk to our partners, to our customers, to our prospects during those two great events that are Arab Health and the Expo Dubai. So as you said, I'm Jérôme Soistier. I'm heading C3 Medical. We're a medical service company, and basically we are partnering with the best French hospitals to try to provide the best of the care to patients worldwide, and also expert consulting to hospitals worldwide, leveraging the competencies of our partners. So I will discuss three topics. First is why it has been discussed already, but maybe precise a little bit more. Why is France a great country to go and get some treatment, high-level treatments? And why is it a good country to get consulting for hospitals across the world? Second is what is needed to enable patients to get some high-level treatments in France? What is the organization that is needed to ensure that this is successful? And third is what we, as C3 Medical, propose in order to meet these objectives. So if we go back to why France is a great country for care, for medical travel, and for consulting, just a few things to add on to what has been said already. Well, in France, a lot of world first are coming from France. And since 1958, more than 150 world firsts are coming from French hospitals and French doctors, which is pretty amazing. And we have quite a few significant innovations that we've seen across the years. The latest ones we can talk about Marie Curie and Pierre Curie, who invented what gave birth to radiotherapy that we can see today, a family with more than 3 Nobel Prizes. But in more recent times, the first artificial heart from the Carmat artificial heart with the Professor Alain Carpentier, or the full total hand transplant that also has been done, which is the first premiere by the Professor Dubernard. So a lot of innovations in health that have taken place in France. In France, about 12% of GDP is spent on healthcare, which is quite a significant number, and we have some general hospitals since the 17th century. So there's a big, long history of medicine in France. Another thing that is important regarding that is it has been said, but France has a very specific approach to care. In France, we say care comes before money, meaning that the first thing we do is we treat patients, We treat patients all the same, meaning patients coming from the outside or patients being French. We provide the same level of care and the same level of expertise. And the other topic which I think is important for international patients or international partners is that in France we do not want to treat all the patients that want to come. Why? Because we only treat when we believe that the French hospitals can bring some added value to those patients. Usually in our activity, we refuse, I would say, about 2/3 or maybe 1/4 of the patients that are asking to come to France. Why? Because our partner hospitals believe or tell us that the treatment that the patients want to undertake is available in his country. So there is no way for him to travel. It can be a cancer protocol, it can be some surgery. We believe, and our partners believe, that if the patient doesn't need to travel, if he can be treated in his country, then we should push for the treatment to take care in the country. Second is, obviously, if we cannot add any value to the life of a patient, most of our partners will refuse to treat the patient. In some countries, if a patient is going to die, some hospitals are still going to accept the patient for money reasons. In France, it's something that very seldom happens. Most of the hospitals, all the hospitals we work with, will refuse to take on a patient if they know, if the specialist team knows that they will not be able to add any value to the life of this patient. So this relation to care, this fairness or this transparency, I think is very specific to French healthcare, and I think is worth mentioning. So it has been said also, but I will re-insist on a topic regarding the network of hospitals and clinics in France. So it's complex network, as we have discussed, and we have, I think, more than 3,000 hospitals in France, 1/3 being public hospitals. So we have the public hospitals, or PHP, which are public hospitals in Paris, which offer some, which are general hospitals, but also are very, very strong in some specific topics. Among others, like transplants. It can be heart transplants, it can be kidney transplants, but also expertise on diabetes, severe diabetes, with specific centers and departments. And then we have some specific hospitals which are smaller, which are private or semi-private, which are very strong also on some specific topics. So we had two presentations, one by the Groupe Hospitalier Saint-Joseph, who has talked about his expertise on cardiac surgery, on gynecologics, on urology, on a lot of specific topics, with a completely an organization which is dedicated to international patients. We talk about the Caen François Bacles Center, but also I want to mention Institut Curie, which is also a comprehensive cancer center. It's been one of the first cancer center created in the world, with the first proton therapy center created also in the world. And today the Institut Curie is treating a lot of patients coming from the world, from across the world, for different type of cancers. Can be pediatric cancers, sarcomas, breast cancers, a lot of complex cancer. So one important thing about the Institut Curie is the fact that the Institut Curie is working together, is having worked together as a big research center and doctors, which is also something that we can say about the French hospital system, is that university, research centers, and clinics and hospitals are working very closely together. So this is those structures that you see here are really state-of-the-art structures. We have, as it has been said, we have all those structures are certified by the French Health Authority. We now have some rankings in France about medical structures in different newspapers, and more and more medical structures are entering into the world rankings. It has been also said by the people before me. So all those structures, and I think it's pretty new, and it's important to mention, are very, very eager to export or to bring their knowledge and their services to the world. Obviously, care is one aspect which is important, and being able to provide best of healthcare to foreign patients in France in the different pathologies that we have discussed. But it's not only care that those structures are looking for, and they also want to transfer or to exchange with international hospitals around topics such as training, and we are very eager to train some international doctors, international nurses, international paramedical staff, and most of those hospitals we work with in France are very excited or very eager to develop this activity. We talk also about consulting or helping clinics or hospitals to develop some new projects. This can be important, or this is important in the area of oncology, for example, where we see in countries around here that there are some significant oncology projects. But in order to build an oncology center, well, you need to define a strategy, you need to define what kind of cancer you want to treat, you need to think about what kind of services or treatment you want to implement. Do you want to implement radiotherapy, proton therapy, research centers? So this consulting, French hospitals can provide very high level of consulting to those hospitals in the region. And finally, research cooperation, because today you cannot research on your side only. It's very important to develop bridges between research departments from France with other countries to be able to share all this data. And obviously, all those French organizations are also today leveraging the latest in technologies, as it has been presented to us: artificial intelligence, genetics, nuclear medicine, and from all stage of a patient care pathway, from analysis at the beginning with laboratories which are more and more sophisticated, all the way to rehabilitation, management of palliative care. So how can we ensure, how do we make it possible that this kind of cooperation is working properly between international patients and the best of the French healthcare? There are a few things that are very important, and it has been a little bit discussed about previously when we talk about conciergerie. It's true that if you want to provide a good support to international patients when they come and get treatment abroad, first of all, you need to be able to prevent, or to orientate, or to direct them correctly. It's important that you receive good medical information, recent medical information, that you have a direct contact with the doctor locally to be able to address or to define where you're going to send the patient. If you need to receive the patient, or if basically you're not going to be able to do anything for the patient. So it's very important to have this front desk, I would say, that can receive the medical information, review those medical information with a specialist, and then orientate or direct the patient towards the right clinic or the right service. This is also true, it's very important also to be able to do that from distance. Today, there is a teleconsultation that exists, so it's a good way to be able to discuss with the patient before he comes, to have a better visibility upon his condition, in order to confirm the diagnostic maybe, and the way where the patient is going to be directed. Second is optimization, because coming to France or going abroad for medical treatment is not an easy task. First of all, people get a little bit anxious. You have some administrative issues that you need to fix, visa. Then all the logistic issues that you also need to organize. It can be transportation, it can be hotels, apartments, taking care of the families that is coming with the patient, getting some medication, and being able to really ensure that the care pathway is going to be structured correctly so that everything goes smoothly. Again, you need to think that the patient is away from home by himself, maybe with his family, for undertaking usually serious surgery. So you need to ensure that things are organized correctly. Then when it's organized, it needs to be coordinated. When the care pathway is going to take place, then things need to happen. Transportation needs to be here. The hospital needs to be booked. Everything needs to be taken care of so that everything is happening properly. Finally, it's cost optimization, because even though we say in France care is coming before money, undertaking medication abroad costs a lot of money, so it's important that we make or that we ensure that it costs as less as possible. And how do we do that? Basically, we try to work with the medical teams in France to provide or to propose the best optimized pathway. So we will ensure that the patient is going to stay as little as possible in the hospitals. We're going to facilitate his exit to a hotel, to an apartment, or back home, to ensure that basically he doesn't have to spend too much money in non-necessary cares. But for that, it's important to be with him. It's important to support him with our medical teams, to make him feel confident that if he gets out of the hospitals, he can get rehabilitation in another structure that is going to be cheaper for him. Okay, so this is the kind of services or the kind of action or the kind of support that is important to provide to patients when they come and get treatment abroad, so that the care pathway is going to be successful and optimized for everybody, for the patient, but also for the payer, because very often the patient is not very often, but often the patient is not the payer. The payer can be an insurance company, the payer can be an institution, the payer can be a company. So it's important to work on both aspects, on the quality aspect and on the price aspect. So C3 Medical in all that, what do we do? Well, we're trying to make that happen. And so we, on one way, we help French hospitals to sell or to provide consulting services to hospitals in foreign countries. And we also help international patients to come and get treatment in France. So we have a different direction or different departments that we provide. One is the medical direction. So we have a medical department that is going to review the medical files up front to ensure a good direction or a good orientation of the patient. We're managing all the administrative and the financial process of a care pathway, which is an important process. We are also communicating, providing support, organizing the logistics for the patients, ensuring that he gets the best experience that he can get undertaking care in France. And we do that with a multicultural team because it's very important when you have a patient coming from Saudi Arabia or from Dubai. It's not requiring the same kind of support than a patient coming from China or from another country in terms of culture, in terms of language, in terms of habits. And you need to be able to answer to those needs and to provide customized or individualized support, which is what we try to do. And just a few figures about who we are. 10 years of experience. We have offices in different countries in the world. We work with plus 40 healthcare partners in France from all kind of partners. And it can be hospital, clinics, rehabilitation center, laboratories. We manage or we follow around 500 patients per year, and we work with insurance companies, corporates, and institutions from worldwide. Thank you very much for your attention.
Thank you. I have two questions for you. You spoke about cost optimization, and you insisted on that point. How does this concretely apply to international care pathways?
Well, the most important thing is to provide high quality of care. So, which is always what we are looking for when we receive a request from a patient to follow a care pathway in France. It's to identify the best medical team to treat his pathology and the best clinic or the best structure. Second, in order to optimize the cost, you have several steps. First step is to ensure that you get all the right information up front, so that you are able to orientate the patient towards the right teams. Because if you don't have the right information, then you may orientate him to the wrong team, the wrong hospital, or you may have him come when he shouldn't have come. So it's very important up front to review closely the medical file to ensure that you've got the right orientation. Second is really, as I said, is to work with the medical team to try to have the best care pathway, meaning to reduce at maximum the hospitalization time, which is anyway something that most of the hospitals in France are doing, trying to reduce the time of hospitalization. So the way to do that is to provide the right support around the hospitalization to be able to takes the patient out of the hospital as if he was a French citizen. A French citizen, he has a family, he has a home, so he can get out of the hospital pretty easily when he can. For international, it's different because they're by themselves, they don't have a home. So you need to be here to create for them all the environment that will make them get out of the hospital early by providing some care in a hotel or in an apartment, having a nurse that is going to come, organizing a session with the kinesiotherapist outside of the hospital, organizing all this care pathway outside of the hospital. And finally, it's to ensure that the patient can go to his country, back to his country as quickly as possible. So it's helping him or his doctor to identify how the post-treatment can be done in his country, so that he doesn't have to stay in France, and also to use technology then to avoid travel for controls and do that by teleconsultation, for example. Okay, so it's really at each stage of the care pathway trying to involve technologies, specific support, logistical organization to ensure that it costs as little as possible to the payer without putting into jeopardy the quality of the treatment and the morale of the patient.
Thank you for this explanation.
Welcome.
And could you maybe illustrate a successful partnership or cooperation between foreign hospital and a French one?
Yes, so we have maybe the latest one we had is we have is with Curie in Tanzania, for example. So Institut Curie has developed a lot of activities in the cancer with the international cancer centers, and they have delivered a strong mission with the Aga Khan Foundation in Tanzania to help the implementation of palliative cares, for example, which is really a key strength of French cancer centers. How you help patients to go through their treatment, and so they have worked and implement very strong palliative care units and departments within several hospitals in Tanzania, together with the Aga Khan Foundation. So this is one kind of partnership. Another partnership is helping, for example, the implementation of a radiotherapy center in a Kazakhstanese clinics and hospitals by providing support to do that. So this kind of consulting is something that more and more clinics and hospitals from France are willing to deliver to improve the local expertise.
Okay, thank you. So now let me introduce you our last speaker, Adrien Rebaud, who are CEO of Billy, and he will present Billy's teleconsultation application, which allows French healthcare professionals to take care of international patients. I don't know if you can hear us, Adrien.
I can hear you.
Okay, I will manage your slides, so just tell me next, and I will move on the next slide.
So first of all, I would like to apologize for not being here in Dubai, but unfortunately for medical reasons, I couldn't go, but I'm fine, nothing serious. Before introducing Billy and our offer, I will start by introducing myself. My name is Adrien Rebaud. I'm the co-founder of Medicam platform, which was created in 2017, and we are specialized in medical treatment of plants and foreign patients, whatever the pathology, from cancer treatment to cosmetic surgery. You can move to the next slide. In few figures, Medicam is more than 100 hospital and clinic partners in the world, more than 5,000 patients treated since the beginning. We are now 16 employees today, and we raised 1.2 million euros a few months ago. At the beginning of the COVID, At the beginning of the COVID, we quickly understood that we needed to digitalize our process for B2B and B2C customers. With the impossibility of flying, we created a fully digitalized platform with teleconsultation as a foundation around our health offer for international patients. That's how Billy was born a few months ago, with a very complementary services launched by Medicam with a strong B2B focus. One of Billy's services is our medical teleconsultation platform for international patients with a French doctor. You can move to the thank you very much. The teleconsultation market is structured around two main segments. You can find the light medicine with surgery and aesthetic medicine, heavy medicine with oncology or cardiology treatment, and general medicine like checkup and teleconsultation now. And we wish to highlight the excellence of French medicine. Our existing patients can now stay in touch with their doctor in France, and our platform gives access to a French doctor from all over the world without having to fly. Our patients come from all over the world, from expatriates, individual businessmen, or people seeking treatment in France because of the quality of care. And we have a wide variety of client profiles. There is also economic advantage depending on the country, because the price of the consultation in the United States, for example, is high compared to teleconsultation with a French doctor. The French doctor touch, as we say, are popular with American patients on leave. The main reason found by a survey of our patients in 80% of cases is to have access to the excellence of French medicine. Our clients inform themselves and do extensive research on internet before choosing a specialist now. And you can consult on video a French doctor from almost all countries like Algeria, Morocco, Canada, Senegal, United States. I say almost because in China we have not deployed a specific server. Today on Billy, 70% of international patients wish to make a video consultation with a French doctor. Just in a few months, we have already reached 3,500 teleconsultations per month, and we are also deploying Billy in a French hospital as a dedicated tool for international patient management. If you can move to the next slide, please, Cécile. On our Billy platform, you can find almost all specialties, like pediatrician, oncologist, orthopedic surgeon, general practitioner, gynecologist, or urologist. We have 3 internal doctors who take care of patients with their daily health problems. All the doctors who enter on Billy are licensed as a doctor of medicine and registered with the French National Medical Council, Conseil de l'Ordre in France. Our referral doctors recommend trusted colleagues in their specialty, in their country or elsewhere in the world. This is how doctors can get to know us and decide to apply on Billy to share their knowledge around the world. We have an internal scientific advisory board, and this allows us to extend our network of doctors and healthcare institutions every day to offer more and more services to our patients in France, of course, but also abroad. If you can move to the next slide, please. In addition to being able to consult the doctor on video, the patient and the doctor have a number of tools at their disposal during the teleconsultation, like in France. With our tools, all the doctor can prescribe a prescription or a care sheet if the patient is European, for example, and they can also talk to each other via chat on the right side of the teleconsultation screen and share documents or photos very easily. All the reports and documents created by doctors during the teleconsultation will be available directly from the application. They can consult them at any time. The patient can share documents with the doctor he has chosen before, after, and during the teleconsultation. It's very useful for neurologists, for example. Of course, we are extremely vigilant about the security of the data, and in order to offer the highest level of confidentiality, we use the technology that allow us to secure the data through end-to-end encryption. So at Billy, we respect and protect your privacy. All the exchanges between you and the doctor are strictly confidential, as well as your health information and medical data. Only the patient and the doctor will have access to them. BD will never sell your data to anyone and will never use it for a commercial purpose. All the health documents are recorded on our digital health record for better tracking on the physician side and on the patient side via our secure platform. You can move to the other one, please. Yeah. Here you can see the dashboard of the doctor's side, on the doctor side. We work on the UX and UI with doctor and patient before developing this panel. As soon as he logs in, the doctor has a global view of his schedule with his patient in the virtual waiting room of patient. We have also developed a very popular feature for our patient, the medical chat. And the doctor answer your question in less than 2 hours on a secure messaging system. The patient can also send photos, for example, in a secure way on the chat. It's like WhatsApp, but for secure with a doctor. We have a third tool on the medical care in the way of an intelligent form to organize the treatment or medical stay by asking for a quotation or recommendations of specialists for a specific pathology in France, for example. With BD, each doctor will be able to exchange with his patient before his trip, for example. A first contact, even in video, reassure the patient and allow a more specific treatment with a global vision of the patient before he travels. In case of the treatment, our teleconsultation tool allows us a free follow-up of the patient for the post-operative surgery, for example. At any time, the doctor can follow his patient in a personalized way with a patient file. This is a function where we find the shared documents, the health forms, for example, PET scan, MRI, and the doctor can also note his observation for a better follow-up of the patient. If you can move to the next slide. Our teleconsultation tool is an important asset that allows us to increase our services around the teleconsultation. We support French companies and startups in managing the health of their employees in France and abroad. We have developed a global solution dedicated to employees to improve their health and well-being on a daily basis. I'm talking obviously about teleconsultation, but even we developed a secure 24/7 platform for employees and their families, an unlimited 7-day-a-week doctor chat plus support, and today we currently answer over 200 questions per day. We have a health support included in France and abroad. We can make a recommendation of specialists who are experts in their field. We just launched our services of interpretation of medical results, for example, an interpretation of your scanner, of your blood test or MRI. And we give access to negotiated rates for our patients. We take care as well to the organization of medical intervention from A to Z in France and abroad. We took care about 5,000 patients from the beginning, and we have a multilingual dedicated care team assistance 7/7 by phone to be assisted in a request. We have also in-house a care team with a multilingual doctor and nurses. This represents 5 full-time people, and the number of the employees should double in the very short time. And I forget the last feature, our baby. We have developed a mental health offer which will be launched in Q. Thank you for your attention. Thank you for the French Healthcare Association and Business.
Thank you, Adrien. I just have one question for you. Can you tell us why is teleconsultation very important before leaving your country of residence?
It's very important for our clients to make a contact with the doctor before traveling. And leaving their country of residence to be treated in France, for example. In the case of surgery, the patient can ask any question he or she wishes to the doctor or of the anesthetics, for example. For the doctors, the information provided during the teleconsultation is very precious and useful. And as soon as the patient returns or go back home, the follow-up is digital in the form of video, and this is always more present than it's more pleasant than the telephone or email, for example. It's easier.
Okay, thank you. So now we have a few minutes for the question part. I don't know if we have some question from the chat. No question. Are there any question in this room or no? Okay, so I have some. So maybe Guillaume Huard, I have two questions. Why would an Emirati patient be treated in a French hospital? Because aren't Emirati hospitals able to treat their national patient?
That's a good question. That's a difficult question also, because what you're underlying here is the complete change of game brought by the pandemic. Before the pandemic, we were signing, I was occupying the position of Dr. Pierre Oupicchian as the counselor of the French embassies in the Middle East, and we were signing some agreements between Department of Health of Abu Dhabi for the international patients to send some Emirati patients to the French hospitals. We signed with Paris Hospitals Foundation, with Saint Joseph Hospital, with Gustave Roussy Institute, and we got in 2018 some very first good results with creation of revenue for these hospitals. And in 2020, when the world closed, all the Emirati patients, all the Saudi patients, or the Kuwaiti patients that were treated abroad went repatriated in their countries. So, of course, they didn't stop the treatment for these patients repatriated in their countries. And after the pandemic, even if the pandemic is not totally finished, from the first contact I get with my former stakeholders, with the former stakeholders I was discussing with at DOH, Department of Health of Abu Dhabi, or International Division of the Patients at Dubai Health Authority, all of them told us, we realized that we can treat our patients in our country, and most of them told us, I'm not sure that we want to send the patients abroad again, because this is very costly. We have to invite all the families, and we have some hospitals on site that can treat the patients. So, having said that, I'm not trying to ruin the conference. I'm just trying to bring some highlights of what I've been working on and what I'm working on now. I still think that for some very specialized type of care, we have mentioned hadron therapy, we have mentioned proton therapy, we have mentioned very highly specialized cancer treatment. We have mentioned also some highly specialized cardiological treatment with Marie-Laine Long and the Saint Joseph Hospital. I think that for this very specialized, dedicated kind of treatment, there will still be a room for the GCC, for the Gulf patients. But why would the patient go to France for a hip replacement when it can be done in the country, when the post-acute rehabilitation can be also done in the country? This is definitely a question that the French hospital that want to treat GCC patients must have in mind.
Okay, thank you. You want to react, Jean-Patrick?
Yes, thank you. What has been to analyze when somebody wants to send a patient abroad is not only the quality of doctors. An hospital, one treatment is not only a doctor's affair. It's a doctor affair, but not only. And so what has been to analyze is how are the nurses, how are the technologies, how are the collaboration between doctors. And when we built institutes or centers, by example on endometriose, endometriose is a very difficult pathology to be analyzed with multiple indications. And so that has to be analyzed to do that. It's a specialization affair, but it's also a multidisciplinary affair. And what I want to say, in the world, there are not so many systems where doctors have a clinical approach. Very often, and we see that in many systems, most time you have biology, you have imaging, and not so often a clinical exam and a clinical approach of the patient. And I'm sure everybody that in France you will find this.
Okay, thank you. So I have a question to go further, Jean-Patrick Lajonchère. What kind of guarantees of quality for international patients care French hospitals at the one you run are able to offer?
I could have answered to that. Really, I'm in great confidence to the French doctors with the clinical analysis, and it's the more important for me. When I go at a doctor and when he speaks to me, when he asks questions to me, when he makes an examination, I'm sure that his diagnostic will be on the right way. So here is why I give the advice to send patients in France.
Thank you. I have a question for you, Lambert Monteleschi. What would you consider to be your main competitive advantages in the medical travel industry?
Thank you. Well, as I said before, we're new players, so we're discovering as we're moving along. I touched on it briefly. We're a small hospital, and I think that's a major added value for somebody coming from abroad. We touched on that point of what it means for a foreign patient to get on a plane, if COVID will allow him to get on a plane, to get his visa, to come with his family. We're talking about cancer in our case, and that's a rather long stay. Proton therapy means that the patient would stay not weeks, but probably months for his treatment. He cannot fly back and forth between the treatments. So your question, what are competitive advantages? The human size, the fact that when you have cancer, you tend to have psychological side effects, and being in a green place like Normandy is probably a nice and peaceful place to relax. And last but not least, the fact that you don't want to be traveling from one location to another, and because Baclès is a comprehensive cancer center, it means it has everything on one site, including proton therapy. So those were the 3 points I'd like to underline.
Okay, thank you. I think we have a question, yes.
combining the treatment in France with prevention locally and follow up after the stay in France? Thank you.
Thank you. Who want to react?
You didn't address the question to me, but I'd like to just say one thing. For example, I mentioned Vietnam. We have a cooperation agreement with Vietnam. Before we can even think of having Vietnamese patients come to France, including because of COVID, we've set up RCP, which is a Réunion de Concertation Pluridisciplinaire, with our Vietnamese colleagues, with Vietnamese doctors. So the two hospitals, before there is patient traffic, are working together on clinical cases, getting ready, getting customized with the different ways of treating patients in the two different countries. There's also a cultural aspect, and it's nice to have the teams working together before patients even arrive. So that's just an example.
Thank you. Yes, I don't know if we can. Yeah, thank you very much.
Thank you very much. In the field of mental health, what could you provide as for an hospitalization or following treatment? Do you have anything to provide from France? I gave the example of Emirati, who has refractory depression or a severe OCD or sometimes substance use disorders. They want to go outside. So what France can provide to this kind of clientele? Thank you.
Problem of the treatment of patients with mental health is going to be the language barrier, from my point of view. We need to treat a local patient in his native mother tongue language. So we have to keep this in mind if we want to treat, especially for substance abuse. We know that we have a lot of countries around the region, Jordan, Egypt, where the Khaliji, the Gulf patients are treated, and if France wants to go on this field, definitely we need to have some Arabic speaker among not only the psychiatrists but also among the health allied that are gonna take care of the patient for the whole pathway.
Thank you. Yes, you can. I'm not sure it's working. Yeah. Maybe I'm sorry because I don't know if you can hear the question. Yes, okay, because it's just me, but it's really okay. Sorry.
You can't hear it. I'm very convinced that France is very advanced in medicine, but as a foreigner who will come to France to treat, say, cancer for several months, my first fear is the language. So to follow up from this gentleman's question, I will not expect the doctor and the nurses, everyone that take care of me, to be speaking Chinese or English. So how do you overcome that? And my second question is capacity. How much capacity does the private hospitals you represent has to take care of overseas patients? I mean, do you have an allocation? How do you deal with that?
Okay, I'll let you answer maybe.
So maybe for the first question related to the translation, or well, usually there's an organization to take care of this language issue, obviously, because you need, when you undertake a long treatment, to be able to communicate with the doctors and also with the support functions that are going to be with you. So we have translators that we work with on a regular basis that are working within the hospital. That can be the translator between the patient and the doctor, and the patient and the nurse for each rendezvous or each appointments, and to try to explain what's going to be done. So we have specific translators that are trained both on the medical aspect and on the language, obviously. And then we have people that can translate during the day-to-day life of the patient, because if he's going to be in France for 3 months or 4 months, so it's not only the meetings with the doctors where translation is needed, but it's also in everyday life for administrative issues, for a lot of different things. So obviously there are some communities in France where people usually find friends or relatives. China, for example, we have a Chinese community in France, so usually when we have patients coming from China for many months for cancer treatment, because we treat quite a few patients from China for cancer in France. They come, so we provide all the translation for the doctors, but very quickly also they found themselves in the community and they meet friends in Paris.
But I'm talking about sick people, so I will not be going out and about, or if I go to Lambert's Hospital in Normandy, I'm not out there to meet friends. I mean, it's your cost analysis. Is it the cost, the translator, for the patient to take?
Well, is the cost, sorry?
Built in.
No, yeah, it's part of the service today. Today, all the hospitals in France that want to develop the international activities, they all provide a service for translation, which is available to the patient during the complete care pathway, whatever the language is.
To complete, we are not saying there that all French hospitals will welcome foreign patients. It's not true. It's not possible. So some hospitals will do that. I don't know how many, but some. And when you speak, and so when we say that, by example, in Saint Joseph, we need partnerships, because I think we know how to do our profession, our medicine, and we need partnership with, by example, C3 Medical, because there are something that they can do better than us, and so we are close on the contracts with patients. Second thing, you ask us for capacity. By example, in 2019 is the last year of reference. On 90,000 stays, we had 900 patients, abroad patients. So I think we are able to go to 1,500 or maybe 2,000. You see, it's 1% or maximum 2%. And that we know to do this. When we have host 1,500 patients, it's very important. It's very important capacity. And so you have the structures to do that. If I would say to you, I will have 100 patients, don't come. It's not serious. We have to do so many to have the know-how and to be able to do that. In the better, it's a world competition, and we have to be, and we are ranked by Newsweek in this competition. And to be in this competition, we have to provide high-level services.
Thank you. I'm sorry we don't have time for another question, but thank you very much for your attention, and thank you all the speakers for your very interesting point of view and intervention. So thank you very much. Have a good lunch.
and I will give the first presentation. So first of all, Unicancer is the French Federation of Comprehensive Cancer Centers. We welcome you to this session on innovation for women at risk or affected with female cancer. This session will cover both innovation in preventive and predictive medicine, such as personalized screenings, as well as therapeutic innovations such as proton therapy and immunotherapy. This session will benefit from the presence of 8 internationally renowned speakers. So Eric Lambaudy from Institut Paul-Calmette, Alexandra Léry from Gustave Roussy, Jean-Louis Abran from Centre François Baclès, Suzette Delaloge from Gustave Roussy Institute, Dominique Stopal-Leonet from Institut Curie, Christine Rousset-Jablonski from Centre Léon Bérard, and Eric Leblanc from Oscar Lambré Center. I am Frédérique Penault-Llorca. I am working in a comprehensive cancer center in Clermont-Ferrand, France. And the subject of my talk is about genomic signatures and therapeutic de-escalation in breast cancer. One in 8 women will be diagnosed with breast cancer before the age of 85, so it's a major public health issue. For each new patient with breast cancer, we have to take account several parameters. So what is the context of discovery of this cancer? And what will be the treatment for the patient? So we have different options depending on the biology of the tumor, chemotherapy, radiation therapy for the locoregional treatment, and endocrine therapy. And for endocrine therapy for specific subtypes of cancer, we have to discuss the type of endocrine therapy, how long, 5 years, 7 years, 10 years. Then we have to take into account several elements of decision. What is the prognosis of the patient, so the risk of relapse, local and distant relapse, short or long-term relapse. What will be the chemosensitivity, so the prediction of response to chemotherapy. What is the potential hormonal sensitivity for the prediction of response to endocrine therapy over time. And what is the context, and this is very important, what is the general condition of the patient, what are the comorbidities, and what will be the personal choice. And we know that some patients, when they arrive with a diagnosis of breast cancer, they are not keen to be treated, so we have to have this discussion with them to decide the treatment options. In fact, we use several parameters to decide what will be the personalized treatment program for the patient. We use the classical parameters such as the TNM parameters, so the size of the tumor, the node involvement, the metastasis. And as it will be shown later, with the mass screening of breast cancer that is developed in our country, more than 2/3 of the patients will arrive with very small tumor. And with that, we have to take into account other parameters like the biology of the tumor. And for that, we have the pathological examination of the tumor. This is my job. I am a pathologist. So we look at tumor grade, histological subtypes, the biology of the tumor per se, so ER, PR status, estrogen, progesterone, and another important marker that is HER2 because we have targeted therapies for that. We look at proliferation of the tumor and other prognostic factors such as vascular invasions. The age of the patient will be also very important, and the surgical margins will be important for the radiation therapy. And in fact, we have several treatment options, and I will focus my talk on the part of that represent the majority of breast cancer, more than 70%, of patients who have tumors that express estrogen and progesterone receptor and that don't express HER2. And for these patients, we have a lack of precision concerning their prognosis and their chemosensitivity. So molecular signatures that are gene expression signatures have been developed in this group of patients with tumor expressing hormones to help us to decide for chemotherapy or not. And we know that in the past, many patients receive chemotherapy because of their tumor size or node involvement. And now we are in the process of treatment de-escalation. So we have, at least in France, four gene expression signatures: Oncotype DX, MammaPrint, EndoPredict, and Procinia. So we use our classical parameters, so microscopic evaluation and standard clinical parameters to define clinical risk between low risk and high risk. And we can use for those patients also gene expression signatures that will help us to define the risk. Are they low risk by gene expression signature or high risk? We conducted a study looking at what are the treatment decisions before, based on clinical data. So you can see here that majority of the patients were classified as eligible to a treatment combining chemotherapy plus endocrine treatment. And after the use of those molecular signatures, we observed a decrease of 60% in the chemotherapy decision, and 13% of increase in chemotherapy among patients who were initially prescribed with endocrine treatment. So this is really important to define a precise treatment that is suited to the biology of the tumor beyond the clinical parameters. So we had a 44% of change in the treatment decision. When we use those gene expression signatures, we can answer to different questions. For who do we need chemotherapy? So for aggressive disease. And how long will we prescribe endocrine treatment? Because it's not chemotherapy, but it's not like taking a mint pill. It's a treatment with a lot of side effects that could be very difficult to endorse for a patient for a long time. So at Unicancer, we have participated to major clinical trials, like the MINDAC trial. UCBG was the first contributor in the world. And with this clinical trial, using MammaPrint signature, we showed that 46% of patients with high clinical risk and low molecular risk can avoid chemotherapy, and they represent 23% of the patients. We also participated to a Responder trial. This trial, where we were also a large contributor worldwide, included patients with invaded lymph nodes, 1 to 3 positive lymph nodes. Usually those patients received chemotherapy. And this trial showed that for the postmenopausal patient with a low risk gene expression signature with the Oncotype DX signature, they didn't benefit from chemotherapy. So it was a major change for those patients. But we show also something very important, is that for premenopausal patients, about 23% of the population, those patients still benefited from chemotherapy. We also participated to other trials and designed one trial from our UCBG Unicancer group at Unicancer Research Group, the ASTER trial, looking at the benefit of chemotherapy in high-risk gene expression signature. So this trial is very important for elderly women, women after 70 years. And another trial looking at hormone therapy duration, the LESS trial for postmenopausal patients. The aim is to shorten endocrine treatment to 2 years instead of 5 or 7 with patients with ultra-low gene expression signature. So we use different molecular signature for that, and those trials are, ASTER trial will be published this year, and LESS trial will start this year. Then we also explored other strategy, a strategy of neoadjuvant treatment. So the tumor is not operated up front. It's the NeoPAL trial using a gene expression signature to select neoadjuvant therapy with ProSigna's signature. And another trial looking at patients with a high clinical risk, the UNIRAD, that was published this year, to intensify endocrine treatment in case of an high-risk gene expression signature with the EndoPredict signature. So we used all those signatures with the aim of having a more precise solution to offer to our patients in our research group from Unicancer in the UCBG breast cancer group. And using that and being really active members of the different trials, international trials, I think that we can say that for breast cancer, expressing hormone receptors and not expressing HER2, therapeutic de-escalation is a reality, as well as tailored, personalized strategy in breast cancer. And with that, I thank you very much for your attention. So now I'm introducing the next speaker, Professor Eric Lambaudy.
Good afternoon, everybody. I'm Eric Lambaudy. I'm an oncologic surgeon in Pauli Calmette Institute, Comprehensive Cancer Center from Unicancer in Marseille, France. And thank you for this opportunity to present the role of enhanced recovery after surgery and rehabilitation in the management of advanced stages of ovarian cancer. These programs are multimodal approaches of perioperative patients' clinical pathway designed to improve surgical but also oncological outcomes. Next slide, please. This patient-centered management refers to a specific organization in which the patient is informed and plays a involving surgeons, anesthesiologists, nurses, dietitians, physiotherapists, but also medical oncologists, geriatricians, and more recently fitness coaches include preoperative counsel, optimization of nutrition, standardized analgesic and anesthetic regimens, the use of minimal invasive surgery each time feasible, limiting drains and catheter placements, and early mobilization after surgery. Next slide, please. This.
Oh, sorry.
No
I have to go back. Okay.
Perfect. This patient-centered management refers to sorry, I missed my slide too. As illustrated on this slide, rehabilitation and ERAS must be integrated during the patient's clinical pathway from the diagnosis to the surgery during neoadjuvant chemotherapy, for example, to improve nutritional, physical, and psychological status, and to limit post-operative morbidity, and also to improve the return to intended oncological treatment, which may constitute in the future a quality indicator of our oncological clinical pathways. Next. This ambitious and cost-effective strategy needs to close collaboration between health professionals involved in these clinical pathways to recover patients' autonomy with a shorter hospital stay as a consequence of less post-operative morbidity. For oncological indications like ovarian cancer, these programs may have an impact on oncological outcomes, improving return to intended oncological treatments, RIOTs, and limiting morphine consumptions. Next. But clinical trials are lacking. It is the reason why we have designed the training trial promoted by my institution, Public Health Institute, but with the financial support of the French National Cancer Institute and the participation of 6 comprehensive cancer centers from Unicancer. Training is a phase 3 randomized control trial with the main objective to determine if a rehabilitation program during neoadjuvant chemotherapy for patients treated for an advanced ovarian cancer will limit physical alteration between the diagnosis and a major abdominal pelvic surgery. 2 groups will be defined, a control group without rehabilitation program and an experimental group with a connected rehabilitation program. Secondary objective will include the analysis of morbidity, quality of life and oncological outcomes between both groups. Training will open this year. Thank you very much for your attention. Next.
Thank you very much. So now I'm giving the control to Alexandra.
So, hello, thank you very much. So I'm Alexandra Leary, I'm a medical oncologist at Gustave Roussy, and we're shifting gear today. Okay. There we go. So here we're going to talk about something quite different. Here I've chosen to focus on a fairly rare tumor that affects women. That's a female cancer, and here it's uterine cancer. And here I chose to present sort of a success story, okay? A lot of people have heard about immunotherapy to fight cancer, and there have been great successes in other tumor types like lung cancer, melanoma, bladder. But actually, to date, there had been few successes in female cancers. We're starting to get there in breast cancer, and here I decided to show an example in uterine cancer, where we're finally actually getting there, and I would argue it's one of the champions now. So a little bit of background on what is immunotherapy and how come it works. So we know here, if you see a cancer cell, it's in green, and the little red cells are immune cells, is that our immune system can attack foreign organisms like bacteria or viruses and can eliminate them. And now we've been now for a few years known that these immune cells can also attack cancer cells. Okay, and so there's been a revolution in cancer treatment, which is basically to give drugs that boost the patient's immune system to make it even better at attacking cancer cells. Okay, so which cancers respond best to not chemotherapy, to immunotherapy? Well, essentially, your immune system is going to recognize something the more different it is from self. That's why viruses, which aren't self, are recognized by the immune system. So it's, to some degree, the more mutant a tumor cell is, the more different it is from a normal cell, the more likely it will be recognized by the immune system, okay? Here I've chosen to illustrate with X-Men, who I'm sure most of you know, which are mutant human species, and obviously they're quite different from most of the people walking down the street. Now that's all fine in X-Men, but actually in cancer, what makes a cancer cell more mutant, more different from a normal healthy cell from which it is essentially derived? Well, one way to make your cancer cell very mutant is to subject it to a lot of extrinsic damage, and that's what we've done with sun and with cigarettes, and these cause cancers like melanoma and lung cancer, okay? And all of this extrinsic stress will basically cause cancers that are very mutant, and that's why these were the first 2 cancers that responded to immunotherapy. They're so different from normal cells that your immune cells picks up on that, then you boost with immunotherapy, and these cancers respond very well, okay? And these are because they're very mutant. So that's all good and well, but how about our female cancers? Do we have certain women's cancers that are highly mutant? and thus would be a good candidate to immune therapy, okay? And again, to some degree, when you look at a tumor, the uglier it is, the better in terms of responding to immune therapy. The more different it is from a normal cell, the better. Okay, and so what can turn, and here again I'm back to my X-Men, Jennifer Lawrence and her Mystique X-Men, well, it can be either extrinsic damage, and I've given you those examples, or actually it could be an extrinsic defect, okay, something that does that the tumor doesn't repair damage well, okay, and that's where it becomes relevant to some women with uterine cancers. Our cells are continuously replicating and making mistakes. But that's fine because we have all these systems within our cells that repair mistakes very, very well. And here I'm going to give you one example. It's one of these repair mechanisms called the mismatch repair system. That basically means if you get a point mutation, and here's a little error, black nucleotide here, well, it's recognized, removed, replaced, and you've got a perfectly normal cell. Now, what happens in certain kinds of uterine cancers and other types of cancer, actually, but uterine cancers are the most frequently associated with this defect, is that their system of repair, here it's their system of MMR repair, does not work. So they get a point mutation, an error. They don't see it, they don't repair it, and here you have a cancer that's very different from a normal cell. And this is what we call a hypermutated uterine tumor. So cancer of the uterus that's hypermutated, all the cancer cells look very different from a normal cell. So do these hypermutated, which we also call MSI, uterine cancers respond to immunotherapy? And the answer is yes. If you look at these hypermutated cancers of the uterus under the microscope, they're full of immune cells, so that if you boost them with an immunotherapy, they actually respond. And we have half of patients that have this type of uterine cancer. You give them an immune therapy every 2 weeks, 3 weeks, 4 weeks, 6 weeks, depending on the immunotherapy. Over half of them will have shrinkage of their tumor, and some of them the tumor disappears completely. The important thing is it's quite easy to identify women with this kind of cancer because we have an easy test, okay? And this is important because it concerns a quarter of women with uterine cancer. They will have these hypermutated MSI cancers, and these respond exceedingly well to immune checkpoint, immune therapies. Why has this revolutionized what we can do for our patients? Well, the standard of care in uterine cancer is depressing. We have first-line chemotherapy, and that's it, nothing else, okay? And so until now, women relapsed after first-line chemo, there was an unmet medical need. We had nothing to offer these patients. Well, now we know that if they have these hypermutated MSI uterine tumors, we can give them immunotherapy. They've been approved by the EMA, the FDA, and that's really changed things. And as I said, we've treated most of these studies that led to the demonstration of immune therapy and these rare kinds of uterine cancers were conducted in France. We were among the best recruiters, and some of these women have complete disappearance of their disease. You can stop the immune therapy, and I'm seeing some 2-3 years after stopping the immune therapy, and they still have no visible disease. And this is raising the intriguing concept that maybe we might be curing a subset of these patients. So, in conclusion, I want to just highlight a French trial. It's going to be led internationally, but it's initiated by French academic groups. And here's to say that's great. So immunotherapy works well after chemo. But how about in first line instead of chemotherapy? And here we have the Dominica trial, which is going to take anyone with these hypermutated uterine cancers that's not eligible to local therapy, and they'll be randomized to standard of care, which is, as I told you, chemotherapy or an immunotherapy. And what's particularly interesting for our patients in this study is if they were randomized to standard of care with chemo and they don't do so well here, they can actually cross over. Okay? So I think hypermutated MSI and uterine cancers are the new champion of immunotherapy. Okay? You can identify them, and they have among the best response to immune checkpoints. Okay? And this to me is the first demonstration of an unprecedented benefit for this novel approach against female cancers. And French sites participated very largely in the trials making this proof of concept. We can identify them easily. And while we have it today for patients progressing after chemo, what we really want to do next, and here the French investigators have a major role, is can we even bring this immunotherapy to the first line to get rid of chemotherapy altogether for these women. And so that's all I had to say. An anecdote, but I think it's a positive anecdote, and French investigators contributed. So that's what I want to say today. Thank you very much.
Thank you very much, Alexandra. So I'm asking for control now.
I've given it back.
Thank you. Thanks a lot. So now I'm giving the end to the next speaker. If it's working. Okay. Okay, so sorry. I moved too far.
Yes.
So Jean-Louis, the floor is yours.
Thank you very much for inviting me, and thanks to the organizing committee, Unicancer and Healthcare, of course, to ask me to present some data as far as proton therapy. It's always a pleasure to talk of proton therapy. I've been involved in this field virtually since the beginning of my career, when I was at the time in the very first center in the worldwide, which was in Boston. And today I'm talking on behalf of the University of Normandy in Caen and of the François Baclès Comprehensive Cancer Center, again in Caen, where I've been developing one of the 3 existing proton therapy centers in France. I've also been involved in the development of the first one in Paris. So it's a pleasure to provide you with some insights of what proton therapy is and what could be the indications as far as breast cancer is concerned. It's only a preliminary experience, of course, but I think this is interesting. Next slide, please. Good. Next slide. Well, okay. So as you know, radiation oncology has enjoyed considerable developments in the very early time of 96, when it was experimented for the first time both in France and US. And for example, we have based our technology on very primitive approaches in the past, like just anatomical landmarks in the patient, and later on 2-dimensional imaging. And then in the 90s, there was a considerable improvement with the development of 3D radiation oncology. And since the 2000s, what is amazing is the introduction of the intensity modulation of the beam, which again has revolutionized radiation oncology, which is called IMRT. And the most advanced technology is based on robotic approaches as well, are called, could you put the entry, please? I don't have control, unfortunately. So yes, so the most advanced technology are called tomotherapy and cyberknife. So we probably heard of it, and now this represents something like 80% of our indications. But what has been just showing up on the right-hand side is that we have also more recently developed programs based on heavy charged particles under the barbaric name of hadron therapy, named from the physics counterpart. And in this context, proton therapy is probably the most developed at the moment, and is really a new revolution in the field of radiation oncology. On the right-hand side, you can see one of these novel treatment rooms based on proton therapies. This is, by the way, the treatment room that we are currently driving in Caen. And as I mentioned to you, there are 2 other centers in France. Next slide, please. So just to remind you very basically what is the difference between the photon therapy, the conventional photon therapy based on the conventional photons that are treating the majority of our patients, and proton therapy. On this slide, you have a very straightforward explanation showing that photons don't stop when they are going through the body, through the biological tissues, unlike particles, and especially protons, that can stop at some point. And for example, when you consider a tumor located in depths, which is the red area on my diagram on the left-hand side, definitely it's clear, looking to this diagram, that the dose which is delivered upstream of the target volume is lower based on protons compared with photons, and this is somewhat clear. But what is more evident, even more, is that the dose which is delivered downstream of the target volume of the tumor is definitely totally different. It's virtually zero considering protons, so you have this sharp fall-off of the dose beyond the target, unlike photons that go through and through and deliver some unnecessary dose to the entire path of the radiation. And so one of the typical difference can be evidence on the right-hand side of my slide, comparing a proton beam and a photon beam. The photon beam, the X-ray beam on the left, for an orbital tumor, evidences that there is a substantial dose that is delivered to the anterior part of the brain, for example, and even to the contralateral eye, unlike the proton radiation that stop abruptly beyond the orbit and spares totally the rest of the CNS and the fellow eye. Next slide, please. And so in this context, proton therapy has been developed in selected indications. As I mentioned to you, it's only a minority of patients nowadays, even in developed countries that can benefit from protons. And I can roughly say that there are three major indications at the moment. On the left-hand side of my slide, it's the ocular tumors, and it has been really a major advance in the management of ocular tumors to consider protons as a conservative treatment, and mainly in the ocular melanomas. On the middle is this funny type of tumor called skull-base sarcomas, a variety of sarcomas that are highly radio-resistant and develop very close to anatomical critical structures like the spinal cord or the brainstem. So they are developing in the skull base, spinal and paraspinal area. And the last one, but not the least one, on the right-hand side, concern the pediatric malignancies, in which the issue is not to escalate the dose and provide more dose in order to improve the local control of our treatment, radiation treatment, but mainly to spare the normal structures that are tissues in development and very sensitive to radiation. And protons do an excellent job. Could you push to entry, please? Okay, thank you very much. And so just to illustrate these three situations, on the left, a patient treated for an ocular tumor at the Paris Orsay Center that I have been ruling for many years, by the way. So a very accurate treatment with submillimetric positioning. On the center, you can see the dose distribution on this color wash representation of a sarcoma, of the skull-base sarcoma, in which there is a tight conformation of the red area, which is the high dose region, to the tumor, while sparing some structures very delicate, very tricky to spare in the middle. This is the spinal cord and the brain stem. And what is also remarkable is that the mid and low doses, which are so abundant as far as X-rays, are virtually totally absent as far as protons are concerned. On the right-hand side, again, a common indication in pediatric tumors, which are the medulloblastoma, a tricky type of radiation that aims to cover the entire brain and spinal canal. On the left is a patient treated using protons, since nowadays we are treating medulloblastoma in some centers using protons. Very tight conformation again to the brain and to the spine. To the middle is the elegant photon treatment, but now nevertheless, as you can see, all the green area, which is located anteriorly to the body, is a part of the body receiving some unnecessary dose and possibly with further complication, especially in a child. And the right part of this final intercomparison is the difference between protons and photons. And all what is covered with photons and not with protons is displayed in green. And so a vast area of the chest, of the abdomen, and of the pelvis is unnecessarily treated using protons. So definitely I'm an advocate for proton therapy. Next slide, please. So definitely, this take-home message is quite important. We are reducing toxicity by dealing with protons. As far as breast cancer, so this is only very preliminary, but I would like to mention that sparing the normal tissue is not a trivial issue. We are mentioning here 2 slides indicating that following breast cancer, there can be some unnecessary toxicity due to radiation. On the left is a paper which has been famous by Dr. Darby, showing that there is a definite increase in the risk of coronary events and of cardiac toxicity for each gray, which is administered unnecessarily to a patient. And this makes, of course, a big concern as far as long-term side effects following breast irradiation in terms of cardiac events like coronary artery disease, mainly. We also know some other forms of toxicity like pericarditis, etc. And on the right, again, some other forms of toxic events following radiation of the breast, especially pulmonary events in terms of pulmonary fibrosis and also long-term secondary pulmonary cancer that goes with other forms of toxicity concerning a bit more rarely the esophageal tract, etc. So next slide. So toxicity is a critical issue as far as breast cancer is concerned, and we also have to be very careful of this. We add toxicity to the existing toxicity of chemotherapy, and dealing with the most innovating approaches in radiation oncology is not something trivial, is not something irrelevant, and I think this is very important. Next slide. Okay, I would like to illustrate what we are doing at the moment dealing with the protons in our center, which is to examine case by case patients that could potentially benefit from proton therapy or that can actually benefit from proton therapy. This is the story of a lady treated for the past year, a very young lady, 33 years of age. She had a past familial history of multiple familial cancers, so definitely a patient at risk. At presentation, she had an advanced disease, a big mass which is visible on the MI on the right-hand side, palpable nodes that are also visible on my actual slide, view. Pathology was consistent with the grade 3 ductal carcinoma, and molecular biology evident that she had a Lee-Fraumeni syndrome, which is characterized by deficient TP53. You know that gene is very important in terms of preserving the genome from alterations. The staging concluded that this was T3, triple negative, and the patient benefited from a very severe treatment, so to speak, but necessary treatment, combining chemotherapy, then mastectomy, since there was no superb response to chemo, and then radiation. And when the radiation came, we had the challenge to keep away as much as possible from toxic events, especially from secondary cancers that are not uncommon in this type of situation. And we elected for protons, and we are lucky enough to have a proton therapy center. This patient is doing perfectly well with 1 year follow-up. And to show you that we are definitely right by electing to treat her with protons, I'm showing you those intercomparison between photons and protons that we performed in this lady. On the left-hand side, you have the photon treatment, the X-ray treatment, and on the right-hand side, you have the proton treatment. And this color wash distribution shows that evidently the patient is well treated as far as her chest wall and internal mammary node by by choosing advanced photon technology versus proton therapy. But what is quite different is the mid and low doses that are spread out all over the chest in this lady. And this was, believe me, an advanced photon technology called arc therapy, a form of intensity modulation. And evidently, the majority of the lungs, of the heart also, are receiving some dose which is absolutely unnecessary for cure of the patient, versus protons, in which we have a superb sparing of lungs and cardiac structures. Next, well, so the protons win in this sort of situations. Next slide, please. And so, in conclusion, there is pros and cons. In my opinion, the pros are largely superior to the cons. Protons have proven highly successful in the selected cancer indication, as I mentioned before, the ocular tumor, the intracranial condition, the spinal tumors, and the pediatric oncology, where it's now routinely applied in a number of centers worldwide. It gains more and more interest in more common cancer. Breast is not the only one. We are treating also now almost routinely esophageal cancers, pancreatic cancers can also benefit. There is a very large experience in prostate cancer. It's becoming so a must for preventing radiation-associated risk. And so this is, I think, my main take-home message. And so as far as breast cancer is considered, I think we should push our colleagues from the breast groups to consider for proton therapy patients that are young, who are young. We have genetic disorders and family history, and so some risk of further secondary malignancies. Those who have heart disease, of course. And so, again, what I didn't mention before is the anatomical abnormalities. We have some funny cases with some forms of malformation of the anterior chest wall called pectus precubatum, for example. And so we have been treating some of these ladies using protons. And in some situations, we can also advocate that proton can do a good job for re-irradiation. Re-irradiating a second course of irradiation in a patient with relapsing disease is not a piece of cake. And protons, after a careful examination, of course, of the entire medical history and previous irradiation, can benefit from second course of proton therapy. We are doing it from time to time. The cons is, of course, the limited availability of the proton therapy center. Only 3 in France versus thousands of photon centers in our country. There is a waiting list which is generally protracted. There are potential contraindications, but few contraindication actually, and we also advocate, our colleagues advocate, that there is a lack of published clinical series, especially control trials like phase 3, and some potential reimbursement difficulties from the health insurance company and the public authorities. Next slide. So thank you very much. I also thank my colleagues from the Curie Institute I've been discussing with in the field of breast, and my colleagues at the François Wagner Cancer Center in Caen. And so I would be happy to reply your questions. Thank you very much.
Thank you very much, Jean-Louis. So we have received several questions. For the sake of time, I will only ask a few of them. So one question for you, Jean-Louis. Do protons decrease the risk of second cancer as well?
Well, this is one of the main goals of proton therapy, since as I mentioned to you, with this intercomparison in the same patient, the low and mid dose are far below when you are considering protons. It's very difficult to prove at the moment, since you need 15 to 20 years to evidence this sort of advantage. But this is, in theory, one of the main goal of proton therapy. It's not the only one, of course, but hopefully we will enjoy some decreased risk. There are still few, but there are, say, few publications showing that there is less risk. My colleagues in Boston, as I mentioned to you, I was part of the group 35 years ago. And the group in Boston, for example, published an intercomparison. It was not a randomized, but an historical intercomparison between photon therapy and proton therapy, showing that there were less risk of secondary cancer dealing with protons. And in the field of pediatric tumors, it was also shown in a recent paper that following the irradiation of a retinoblastoma, a cancer that can occur in the eye of very young children, the risk of secondary cancer, which are in this case very bad osteosarcomas of the fascial bones, was less dealing with protons compared with photons. So there are still some preliminary evidences of the advantage of protons. I have to say that if at some point, undoubtedly protons do a better job in terms of sparing the patients from secondary cancer, it would be a really a tsunami in the field of radiation oncology, because it would mean that most of the radiation centers should have a proton unit, because if it's superior, our patients will request adamantly to have protons versus photons. But I may be a little bit enthusiastic in this field, but
I think it's a very good point. It will be very expensive and difficult to implement for the moment, but it's a very good point. I have a question.
Yes, yeah.
Sorry.
Okay. No, I would like just to mention that it's of course an issue. Proton treatment is considered something like 5-fold the price of a photon treatment. And my colleague in Curie, for example, wanted to have an academic trial conducted in breast cancer. And unfortunately, the reviewers of their project declined to enter in this very interesting study, because it was considered too expensive, and of course our national healthcare system would have to pay for the difference. And it's very unfortunate, because in the long run, we are saving lives and we are saving money for secondary cancer management, for example, dealing with protons. But
thank you. I have a question for Alexandra. What is the prevalence of MSI plus uterine cancer? So how many patients can benefit from them? And how many have Lynch syndrome? So familial predisposition for uterine cancer?
So 25 to 30% of women with uterine cancer have an MSI tumor, so it's almost a third of the patients, especially in the relapse setting. Amongst those, only about 5% will have Lynch, so the 90% will be somatic MSI and not linked to an inherited predisposition.
Okay, thank you. And I have another question about cervical cancer, because that's true that we are very disappointed about immunotherapy in female cancer, and we expected a lot from cervical cancer with the HPV infection. So you have
yeah, so the first data that led to approval in the States was in the relapsed pre-treated cervical cancer, where the response rate was only about 15%. So that led to approval in the States, but not in France. And we just had the results of the first line setting. So in cervical cancer, if you wait till they're heavily pretreated, these women are tired, they have fever, they have high platelets, low lymphocytes. Once they're heavily pretreated, they're not going to respond to immune therapy. So you need to put it earlier. So we finally have a first positive trial in the first line setting with chemo, and that improved overall survival and progression-free survival. So that's the first data, and I think we need to move it even earlier in combination with chemoradiotherapy and the curative setting, and those trials will be reading out within the next year.
Okay, thank you. We had also questions for Eric Lambaudy. So Eric, the women with ovarian cancer are usually old. I am in this category, more than 60, and they, I think, you know, the approach of enhanced recovery after surgery and the rehabilitation is really very important. Who is the older woman you have in your trial, and what is your aim? Is it okay for them to accept this kind of approach, or you have seen also experienced limitation with women after 75 or
We all know that the age is not always a good indicator. That's why we need to work very closely with our colleagues, geriatricians, to evaluate our patients. And we do not have any limits concerning the age of the patient. It depends on the patient. So actually, the trial is not open. It's going to be open, I hope, in February. But due to the pandemic, it's not so easy to open. The difficulty in our trial is that the rehabilitation program will be connected. It means that all our patients involved in the arm rehabilitation will have connected watches and will use at home scale, body fat scale. We have this difficulty, the difficulty of the connection of the digital part of our trial. But I hope it will work, and we will have a bias in our trial, certainly in the selection of our patient. But if we talk about the classic rehabilitation, it means nutritional, physical, and psychological support. We do not have any limit concerning the age of the patient.
Okay, thank you very much. So I just had one question on my presentation, so I'm going to ask it to myself. I have presented the data and all the development that we did at Unicancer for ER positive, HER2 negative breast cancer with the molecular signatures. And the question was, do you have molecular signatures for the other type of breast cancer? So the answer will be very short. We don't use them right now in clinics and in clinical trials, especially for HER2. It's a kind of not a nightmare, but it's a kind of disappointment from us working for so many years on that. We didn't find really consistent predictive signature of response, but we are starting to have some data on that. And for triple negative breast cancer, we know that we have some molecular subtypes that could indicate a better response to immunotherapy or PARP inhibitors, for instance. For the moment, it's not in the routine practice. It's still on research. I think that now we have to move to the second part of our presentation. So the part on the innovation in preventive and predictive. So you can go.
MyPEBS, my personal breast screening. MyPEBS is a clinical research study testing if it is at least equivalent, or even better, for women to have personalized breast cancer screening based on their individual risk of developing a breast cancer instead of standard screening based on age. To answer this question, we are comparing two screening strategies: the current standard screening in our countries, where age is the only factor considered when inviting women to mammography screening, and a personalized screening strategy, in which how and how often to screen is decided on the basis of individual risk level. Because not all women are the same. Everyone's risk of developing breast cancer is different, depending on genetic factors, density of breast tissue, family and health history. MyPEBS is currently recruiting volunteers. We'd like you to consider joining this study. If you decide to join the study, after getting all information and reading the information sheet, we will ask you to sign an informed consent form and to answer some questions on your medical history, family cancer history, and reproductive history. Then, you will be randomly assigned by a computer to one of the two study groups: the standard screening group or the personalized screening group. The chances of being in either group is 50-50, just like the flip of a coin. If you are assigned to the standard screening group, you will follow your screening schedule according to current breast screening practices in your country and area. If you are assigned to the personalized screening group, we will ask you to give a sample of your saliva to analyze your DNA. This analysis will take 2 to 3 months, and we will assess the density of your breast through your screening mammography. MyPeb's researchers will estimate your risk on the basis of the results of these tests, along with the questionnaires you completed at study entry, and will recommend you a specific screening protocol according to your risk level. If your risk is low, your next mammography will be in 4 years at the end of the study. If your risk is average, you will have 1 mammogram every 2 years, and also 1 ultrasound every 2 years if your breast tissue is dense. If your risk is high, you will have a mammogram every year, and also 1 ultrasound every year if your breast tissue is dense. If your risk is very high, you will have a mammogram every year, and a magnetic resonance imaging scan every year until you are 60. Your participation in the study will last 4 years. During this period, we will ask you to follow your screening protocol, to update your information once a year, so that we can check if your risk needs to be reassessed, and to give some feedback about any concern you may have and your point of view and thoughts on MyPebs. You will be able to give us this feedback on your personal portal on MyPeb's web platform. By taking part, you would help to define the best way to screen for breast cancer and potentially improve screening guidelines for all women in the future.
Suzette, on t'entend pas.
Thank you so much. This is Suzette Delaloge speaking. I'm medical oncologist at Gustav Rose Institute, and I'm also, as you bet, the coordinator of the MyPebs study and project. MyPebs is a EU-funded project that is currently going on. So we are turning right now to prevention and screening, early detection of cancer. This is a big area that is in huge development in many of Western countries, including France, of course. So regarding breast cancer, what's the issue? The current issue is that regarding breast cancer screening, we have great data from randomized trials and cohorts showing that there are some benefit from screening, which include 20% decrease in breast cancer specific mortality, lower stage at diagnosis, some chemotherapies avoided, some mastectomy avoided, etc. But there also are some side effects or risks that are associated with breast cancer screening the way we do it right now. And these risks are limited sensitivity, and there are some around 17% interval cancers, even in women who have a 2-yearly mammogram. Some false positive recalls, around 3% of women will get a biopsy for a benign lesion at each mammogram. And there are some overdiagnoses. These are women diagnosed with breast cancer for whom the cancer would not have progressed to anything harmful if not diagnosed. And it's estimated currently, unlike prostate cancer, for instance, that this overdiagnosis rate is around 10 to 15% of all cancer diagnosed, but it's much higher, around 30% for DCIS. And last but not least, not with proton, but with the other techniques we use right now for screening, it's X-ray. So we have a very small, very small risk of radiation-induced cancer. So the risk-benefit ratio is clearly in favor of mammographic screening the way we do it right now, but there is a major need for improvement. So what we aim to is going for personalized prevention. So what we are at is more stratified prevention right now, but personalized prevention is clearly something that is going to develop and will be probably standard 20 years from now. Stratified prevention is already something very important, which means that we are able to identify different risk groups. Towards that, we have very good data. We have risk scores that have been developed over the past 20 years, and during the past 10 years, we could add SNP scores. These are scores that gather a number of polymorphisms that are in link with the breast cancer risk, either increase it a bit or decrease it a bit, and all together have a strong effect on the ability to predict breast cancer. So as you can see here, with the best available SNP score, which is a 313 SNP score that has been described by Cambridge, the discrimination is very good for ER-positive disease, which can predict women with very low risk of breast cancer, and some of them have a high risk, whereas it's also discriminant for ER-negative, but that to a lesser extent due to the lesser prevalence of ER-negative disease, of course. So this is the basis of MyPEPS, which is a randomized study that compares personal risk stratified screening versus standard screening. So it's an international study. Sorry about the strange appearance of that slide. So it's a global project that has been funded by the European Commission, and it is ongoing. We will not look at all details, just to say that very importantly, not only it compares the efficacy of two different methods of screening, risk-based versus standard, but also it evaluates the social, ethical, psychological effects of having one's risk assessed, which is a very important issue. It assesses the economical evaluation of a potential risk-based screening for the future, and there is a lot about communication, etc. So this is the study scheme for MyPEPS. MyPEPS is now open in 6 countries, including Spain, UK, Belgium, France, Italy, and Israel. MyPEPS will accrue women from 40 to 70 years old, women who never got breast cancer and do not have a high-risk situation already identified. We aim to accrue 85,000 women in these 6 countries. And those eligible women are randomized between the R1, which is standard screening for 4 years. So women will continue with the standard screening they were already on before entering the study, or risk-based screening, which is the stratified arm, including the assessment of the PRS, which is inserted in a risk score that takes into account family history of biopsy, age, etc., demographic density, and with that we assess a risk score that will allocate the woman, as you have seen in the cartoon, to a risk category, which is either low, average, high, or very high. And the screening program will be adapted according to the different categories. The primary endpoint of this study is the incidence of stage 2 or higher breast cancer in each group at 4 years. So we already have accrued 25,000 women in our 6 countries. The trial is currently ongoing, but it goes well, and these are good news. So we should be able to provide you with the major answers in some years from now. So the primary objective is to show that this stratified screening is non-inferior in terms of incidence of breast cancer of stage 2 and higher at 4 years. And the first secondary objective is to, if the non-inferiority is shown, is to show a superiority of the risk-based screening arm. And we clearly hope that it should be superior. So we have 6 countries, and Spain has entered recently and opened recently to accrual. Here we go. So all countries are active. This is the screening strategy that is currently proposed in the stratified arm. So it depends on the predicted invasive breast cancer risk at 5 years. If it's below 1%, the next mammogram is going to be 4 years. If it's between 1 and 1.66, then it's a 2-yearly mammogram. And beyond 1.67% invasive breast cancer risk at 5 years, we are on a yearly mammogram and eventually an MRI if the risk is very, very high, equivalent to BRCA carriers, for instance. And to that, we add an ultrasound for all women who have dense breasts. So MyPEPs should be deeply changing the long-term breast cancer screening. The planned outcomes, as we have mentioned, is a strong evidence that has been asked by the European Commission to this trial to sustain the implementation of risk-based screening. And indeed, there are only 2 randomized trials assessing this very important question in the world. One is MyPEPs in Europe, and one is the Western trial in the US. And so this will be the basis for the future European Commission, European Union recommendations. But we also will be able to assess the efficacy and risk benefits for an individual. We will be able to identify target populations of certain types and rhythms of screening, the cost, the psychosocial impact. We will have tools that could and should be ready for implementation in a large scale, and we should have the different stakeholders prepared in terms of communication, etc. But beyond that, of course, MyPEPs is also a very huge database, and it's also a base for a biobank and for images, of course. So we should come out with new risk models, new risk genes, new risk SNPs, new images, and identification of images towards refining risk assessment, etc., new economical models. So it's clearly something that will go much beyond the results of a clinical trial. So this is really a very large enterprise with 27 partners all over Europe and Israel. I thank you very much.
Good morning, everybody. So, ladies and gentlemen, and dear colleagues, I'm going to try to scan a very wide topic in a few minutes, and I apologize in advance for being elliptical. Sorry. Okay. So the last 30 years have built a very large landscape of breast cancer genetic factors, ranging from Mendelian genes to susceptibility factors. And on this diagram, genetic factors are reported in ordinate here according to their relative risk of breast cancer, and in abscissa according to the frequency of the carriers in the Caucasian population. And you can see that BRCA1 and BRCA2 carriers frequency is high and gazer close to 0.3%. That means one individual in 300, which is very high. PALB2, CHEK2, ATM genes are associated with moderate risk. More recently, single nucleotide polymorphism, or SNPs, have been identified through genome-wide association study, and these susceptibility factors are combined in a polygenic risk score, PRS, and PRS is at the heart of the important clinical trial, MyPEPs. The prevalence of BRCA1 and 2 carriers among women affected with breast cancer is about 2.5%, and if you had PALB2, ATM, and CHEK2, is about 5%. The estimation of cancer risk is crucial for defining the management of at-risk women. And in this prospective European study, the lifetime risk of breast cancer in women carrying a BRCA1 pathogenic variant is estimated to 72%. And figures are similar for BRCA2. And women affected with the first breast cancer have a high risk of a contralateral cancer. And the annual risk is 2% for BRCA1 and 1.5% for BRCA2. And of course, besides to breast cancer, there is also a high risk of ovarian cancer, especially for BRCA1. What are the main features of the management of BRCA1 or BRCA2 carrier. Recommendations are similar worldwide. Annual breast screening by MRI, mammo, and ultrasonography beginning at age 30 is recommended. Prophylactic mastectomy has to be discussed. Mastectomy uptake differs by country, high in the US, the UK and the Netherlands, but lower in Spain, France and Italy, for example. Prophylactic salpingo-oophorectomy that will be presented in the next talk is strongly and worldwide recommended at age 40 or later according to the gene involved. Regarding other genes such as ATM, CHEK2 or BARD1 or FALB2, which are, I told you, moderate risk, management guidelines have not yet been established and differ according to the family story, but I would have also to country. And the management the management of women will be improved when we will be able to estimate individual risk by taking into account modifying risk factors. There are clearly factors modifying breast cancer risk. This is illustrated by family history, by the risk of women born before the 40s or born later. That means that lifestyle and environment risk factors are associated, and there are also genetic factors. And you have also here the PRS that I mentioned for my pets, and you can see here for each Mendelian genes the distribution of breast cancer risk at 5 years according to individual PRS. And you can see here in blue, for example, the distribution of risk for different women. All are carrier of a BRCA2 pathogenic variant, but there is a large distribution of risk according to the PRS. And it is expected that next generation of tests will integrate to multiple gene panels such modifying factors. Another challenge awaits us when sequencing BRCA1 and BRCA2 and all genes, besides pathogenic and benign variants. There are variants of unknown significance because we do not know their biological and thus their clinical significance. And views are the nightmare of geneticists and therefore also of the tested woman. And in the French oncogenetic database, FROG, more than 50% here of BRCA1 variants are viewed. And figures are similar in other national or international databases. And international collaborations for classification of views are strongly needed. They are underway through Enigma and the BRCA challenge of the Global Alliance for Genomics and Health. The last part of my talk. The BRCA2 and BRCA1 and BRCA2 genes have been identified more than 25 years ago. But it is only 3 years after their identification that we understood that the BRCA protein were involved in the repair of DNA double-strand breaks by homologous recombination. 10 years later, in 2005, in vitro analysis have shown that the usefulness of stopping the BEF excision repair pathway in BRCA invalidated cells by using PARP inhibitors. And 9 years later, in 2014, the first clinical trials of PARP inhibitors were a breakthrough in the treatment of women BRCA carriers and affected with ovarian cancer. And now PARP inhibitors are useful for a woman BRCA carrier and affected with an advanced breast cancer. in summary and as take-home messages, I would like to underline that BRCA1 and BRCA2 and other breast cancer genes have opened up a new field in medical genetics. Hereditary breast ovarian cancer multi-gene panels are one of the most common genetic tests worldwide. Two main challenges are remaining: the integration of modifying factors in tests and the classification of variants of unknown significance. And BRCA testing is now standard for women affected with ovarian or advanced breast cancer. Women need to have quality tests. They need to be informed and supported because they no longer have choice of being tested or not tested. I thank you very much.
So Christine, your presentation.
Good morning, everybody, and I'm very honored to represent France for this presentation, and I will talk about fertility preservation in women with breast cancer. I am working in Centre Léon Bérard in Lyon. So why should fertility preservation be discussed? Because 5% of breast cancer occur in women younger than 40 years old, and because age at pregnancy desire has become later and later, with a mean age at first pregnancy of 29 years. The period between 30 and 40 years old corresponds to a decline of ovarian reserve, which is associated with a fertility decline. And mainly in women after 30 and mainly after 35 years old, the fecundability, which is the probability of getting pregnant for each month of attempt, falls down. Women with breast cancer will face two factors that can decrease their fertility. First, the toxicity on the ovarian reserve of the chemotherapy, and second, the time that they will have to wait before getting pregnant, and especially in case of hormone therapy that will last 5, sometimes 10 years, and during this time their ovarian reserve will still decrease naturally. We also should discuss fertility preservation because we now know that pregnancy after breast cancer is safe. Strong data conclude that pregnancy itself after breast cancer does not appear to increase the risk of recurrence, and disease-free survival and overall survival even were found to be better among women who have a full-term pregnancy after breast cancer, after adjustment on prognosis factor, and thus avoiding the healthy mother effect. 2020 ESMO guidelines conclude that pregnancy after breast cancer should not be discouraged. But should we intervene to preserve fertility in all women with breast cancer? Fertility preservation is in fact the prevention of a potential future infertility, and so as every prevention, it should be discussed in an individual benefit-risk balance. On one side, we have to take into account the future infertility risk of the woman and the efficiency of the methods that we can propose, and on the other side, the risks induced by these methods. Finally, the methods have to be feasible, and fertility preservation need to be included in the care pathway. We now have some international guidelines that can help us in the decision making, but at the end, this benefit-risk balance should always be assessed individually. So here are the different fertility preservation methods available in 2022. Generation agonists, whose efficiency is still discussed. The ovarian cortex cryopreservation, but which is not the first choice method for women with breast cancer, because this method can damage ovarian reserve more than the chemotherapy itself. And as in BRCA women, the ovarian tissue may not be replaced. Immature oocyte retrieval followed by in vitro maturation, but whose efficiency seems to be low, as only a few births were published until now. And finally, the ovarian stimulation followed by mature oocyte retrieval and oocyte or embryo cryopreservation is the preferred method because of its effectiveness and is considered by ASCO as an established fertility preservation method. But when looking at the benefit-risk balance, especially for ovarian stimulation and oocyte vitrification, one point to discuss is the expected efficiency of this method in terms of number of oocytes retrieved and in terms of probabilities of pregnancy. Some data show that women who use their oocytes after the breast cancer have living birth rate between 32 to 50%. But as the woman gets older, the number of oocytes to retrieve, to have good probability of live birth rate increase. And thus, in women with a low ovarian reserve of age more than 38 years old, the probability of success and the relevance of this method should be discussed. On the other side, concerning safety data, there is still little safety data, but despite the hyperestrogenism induced by the stimulation, the retrospective and prospective observational data that we have show no increase in recurrence risk among women who do this ovarian stimulation in the context of breast cancer. Also, this data concern only diseases at limited stage now. One of the major challenges is to respect the optimal time before beginning the chemotherapy and to integrate fertility preservation in the care pathway to be able to achieve 1 to 2 cycles of stimulation without delaying the chemotherapy. Finally, the decision of fertility preservation should be multidisciplinary, integrating oncologists, gynecologists, and of course the patient herself in a shared medical decision. I thank you for your attention.
Thank you very much, Christine. And now the last talk by Eric Leblanc.
Wow. Dear ladies and gentlemen, dear colleagues, good afternoon, because I think it's afternoon right time in Dubai. I'm Eric Leblanc, I'm a surgeon working in the Department of Gynecology and Oncology at Oscar-Lambret. This topic is the last but not the least, and we'll focus in an important public health care issue, the prevention of ovarian cancer. I will fasten my presentation because we are short in time. Just to say that if this cancer is not the most frequent, it's by far the most lethal. And if ovarian cancer consists of around 15 different subtypes, the most frequent and dangerous is the high-grade serous carcinoma. And it is found in 15 to 18% of people, especially those carrying a mutation of BRCA genes, 1 or 2. And when these genes are mutated, the risk of breast ovarian carcinoma, especially ovarian carcinoma, is very high, up to 40% for BRCA1 between 55 to 70 years old. Less frequently, the genes from the Lynch syndrome may be responsible for ovarian cancer as well. Of importance is that the risk of ovarian cancer in mutated patients, BRCA mutated patients, increase exponentially with time, with grossly 10% risk at 50, 20% up to 60, and 40% up to 70 and above. Thus, prevention is highly desirable. Next slide. So, the first is the screening method, combining ultrasound and biological marker in different combinations, and unfortunately, they were unable to prevent effectively ovarian cancer nor reduce the mortality, because ovarian cancer is a rare disease. 1 woman out of 70 will be affected by this disease, and with a quick evolution as soon as initiated. Combined contraceptive pill blocking ovulation has demonstrated efficacy at preventing the disease, but this treatment is not always tolerated nor indicated, especially in case of history of breast cancer. Finally, surgery seems to be the most efficient method. Tubal ligation used for contraceptive intent has already demonstrated it could prevent ovarian cancer, but especially endometrioid or clear cell, but not the high-grade serous carcinoma. And since the 80s, the bilateral risk-reducing salpingo-oophorectomy or adnexectomy is the most effective and worldwide standard of protection against ovarian cancer, especially in the population of BRCA-mutated ladies. But this prophylaxis is not without detrimental effect on the quality of life of this patient because of osteoporosis, hot flashes, impaired libido, and increase of coronary disease or neurologic disease that may impair the life expectancy. That's why 30% of these at-risk patients refuse or delay this operation, exposing themselves to this dreadful disease. Next one. In the 90s, pathologists using accurate methods of examination found an unexpected rate of abnormalities, especially located at the ovarian extremity of the fallopian tube here, which is called the fimbria. They demonstrated stepwise evolution of abnormalities towards an invasive cancer of high grade. So, although supposed to be at the origin of ovarian cancer, ovary was only a metastase of a tumor born into the distal part of the tube. Thus, a two-step prophylactic operation associating a salpingectomy, removing only the tube, and followed by a delayed oophorectomy sounds logical to prevent high-grade serous tumor while avoiding the adverse effects of castration in early women. And following this concept, we suggested in 2012 to perform a national study, PHRC, for these ladies with a mutation who refused to have the risk-reducing salpingo-oophorectomy. So we performed a radical fimbrectomy, which is the removal of all the tube and the tiny part of the ovary attached to the tube, because some suggested the pathology rose at the stem at the junction between the two epithelia. And the results are now available and are currently under publication. 120 ladies, it's a pilot study, were submitted to this operation, and with 7-year median follow-up globally and 9-year for a specific follow-up, we never observed any ovarian or peritoneal high-grade serous carcinoma. And the surgical morbidity was equivalent to risk-reducing salpingo-oophorectomy. And for those who had a secondary oophorectomy, we never observed any abnormalities on this specimen. Thus, this policy of two-step prophylaxis seems variable and in this high-risk population, and deserves to be tested on a larger cohort of high-risk ladies, as suggested in the international study called TUBA-WISP-2, who will give to the patient the choice between RRSO or risk-reducing salpingectomy with delayed oophorectomy. 3,000 ladies are expected to enter this trial, and it will be a very great opportunity for them, for those who refuse the risk-reducing salpingo-oophorectomy. But for the non-high-risk ladies now, who are candidates for conservative surgery, hysterectomy with opportunistic salpingectomy, keeping the ovaries in place, had absolutely no adverse effect and participates as well at limiting this risk in the general population. I hope I kept my time.
Yes, thank you very much. So I have to apologize for the 4 last speakers because there is another session just after us and we will not have time to take any question. But if there are any questions, you can send them by emails and our colleagues will respond to them. I would like to say that this session, this second part on innovation and preventive and predictive medicine is opening wide hopes for the patients. I think it's really a very large part of innovation to be in this preventive medicine. So I think we have shown this afternoon the excellence of the French Unicancer group in terms of therapeutic innovation and in terms of prevention and predictive medicine. I would like to thank very much all the speakers and I would like to thank the audience for your attention. Thank you very much.
Thank you. Bye-bye.
Thank you.
Thank you.